Morning, friends. It's again welcome to the second day of this program, and for this first session, it's indeed my pleasure and privilege to invite Professor Krishna Raju, Dr. Raidu to join us as chairpersons on the stage. Dr. Rajagopal Raju is unwell because of some upper respiratory infection, so he is not able to join. We'll get started with the first case.
First.
Good morning to all of you. So the first session of the day, 9th session of the conference, we have one case presentation, two case presentations, and two lectures, so total 4 programs. So the first one is by Dr. Preetham Krishnamurthy. I think he's already there. Okay.
Thank you, sir.
The case presentation by you.
Yes. Thank you, sir, for the introduction. Good morning, one and all. I thank Dr. Narasimhan for giving me this opportunity to present an interesting case in this forum. So, this is a 26-year-old female who is 10 weeks pregnant, who had presented with recurrent syncope, was diagnosed to have hypertrophic obstructive cardiomyopathy and had runs of VT in the Holter. She had a SCD risk score of 5.5% and was at a very high risk for sudden cardiac death. Would require an ICD, and but she was not willing for termination of pregnancy. So we had planned for a dual chamber ICD implantation under zero fluoroscopy. So this is a baseline ECG, and this is the cardiac MRI where we can see intraventricular septal diameter of 23 mm and an inducible LVOT gradient up to 40 millimeters of mercury. The late gadolinium enhancement was 18%. So she was there's significant fibrosis, again at a higher risk for sudden cardiac death. So how did we plan the procedure? It was an ultrasound guided left axillary vein access, which was followed by a 3D electroanatomical mapping of the RA and RV using a decapolar catheter, and then ICE guided implantation of the RA and RV leads, and then utilization of ICE to confirm the adequate loops. This was the first part of the procedure, taking an ultrasound guided left axillary vein access. Here we try to visualize in short axis the axillary artery and axillary vein, and then aligned it along the long axis of the axillary vein and punctured the axillary axis with axillary vein under direct ultrasound guidance. Here we took 3 accesses, one for the decapolar catheter and the RA, and the third for the RV. So using the first axis, we took the decapolar catheter, made an anatomical map of the RA, RV and the right atrial appendage, and marked the sites of implantation, possible sites of implantation. So here we are showing how this is the right atrial appendage. This is the and this is the RA view, and this is the LA view. This is the right atrial appendage, and this is the septal aspect of the RV, which we marked here to identify sites of screwing. And this is the LAO view. So the first step is to take the guideway towards the IVC. So here, this is the ICE catheter. ICE catheter has a sectoral view where we can see which the structures anterior to the ICE catheter. So here it is placed at the tricuspid valve at the RA IVC junction. So this is the IVC RA junction. Here we can see the guideway into the IVC. And then pushing the ICE catheter a bit inside, visualizing the tricuspid valve and the right ventricle, we push the guide wire into the RV. So here we push it into the RV apex. So after pushing the guide into the RV apex, we slowly track the sheath, visualizing for any ventricular premature complexes in the ECG, and then slowly pushing the long sheath. We use a long sheath so that we don't have to manipulate much. So this is a Merit 25 centimeter long sheath which we placed into the RV. This is a peel away sheath. So after placing the RV sheath, through this sheath we had taken the RV defibrillator lead. Here we took the ICE catheter into the RV, and we are visualizing the septal aspect of the RV here. So this is the septal, this is the free wall aspect, and this is the apex, and this is the septal aspect. So using our electroanatomical mapping, we were having the direct guidance where we are going exactly in the RV along the septum, along the apical septum. So here we are screwing the RV defibrillator lead again under direct guidance, confirming its penetration into the myocardium. And the second part of the procedure is placing of the right atrial appendage, right atrial lead, tine lead into the right atrial appendage. So this was pretty straightforward. We had taken the lead into the RA, pulled the lead, stillet, and placed into the right atrial appendage. And the last part of the procedure, which usually would require a fluoroscopy, we could do without fluoroscopy help using the eyes by adjusting the loops, just pushing and pulling the leads with ICE guidance. So here we can see a nice looping of the RV lead along the RV into the RV going to the apex. So this was the final position of the RA and RV lead. This is along the appendage. This is along the apical part of this apical septum. And so we could, and the pacing parameters and the sensing parameters were good at the end of the procedure. So the take-home message is HCM during pregnancy can be a clinical challenge. Concurrent use of ICE and 3D guidance allows for zero fluoroscopy during ICD implantation. Utilization of ICE is crucial in ensuring wire sheath and lead entry into RA and RV. 3D electroanatomical mapping of the RA and RV with visualization of the leads on 3D system is useful. Thank you.
They are related. We'll take the questions after.
Questions after.
May I now request Dr. Hisham Ahmad? Dr. Hisham Ahmad?
Yes, sir. Good morning, sir. Thank you. Are my slides visible?
Now, yes.
Yes.
Your slides on the screen.
Yeah. Yes, sir. Thank you, sir. Good morning, everyone. And at the outset, let me thank Narasimha sir and the organization committee for giving me the opportunity to be a part of this meeting today. Over the next couple of minutes, I thought I would just highlight the certain key aspects of hypertrophic cardiomyopathy in pregnancy, certain key perspectives as how we understand the disease due to its unique pathophysiology, especially in terms of pregnancy, and some of the key management issues that one faces in clinical practice. So just a brief review. This is familiar to all of us. We know that hypertrophic cardiomyopathy is unexplained left ventricular hypertrophy in the setting of an absence of an external loading condition and lack of another disease explaining the pathological hypertrophy. And we know that it can be very heterogeneous in its phenotype. It can be asymmetrical septal, apical, it could be mid-ventricular, and of course it can present with a restrictive physiology as well. So the heterogeneous manifestation or presentation of the HCM phenotype is well known to all of us. So we know that it can be explained on the basis of sarcomeric gene mutations most of the time, and in approximately 70% of the time, it's usually the cardiac myosin binding protein C or the beta myosin heavy chain of the sarcomeric apparatus, which is responsible for a pathogenic variant, which can explain the pathobiology of disease. In terms of current prevalence, now we know that we've sort of started to move away from the traditional 1 in 500 to possibly 1 in 200, and that's because of a combination of factors. We're now pursuing advanced imaging, in fact, to identify some echo-negative patients. Sometimes subtle findings may be identified in terms of the HCM phenotype on CMR. Of course, we also have to account for the population which is gene positive and phenotype negative. And of course, we are now undertaking systematic familial screening, genetic as well as clinical, and that could be the reason why the estimated prevalence is now being upgraded to close to 1 in 200 right now. We're also familiar with the two hemodynamic subsets of hypertrophic cardiomyopathy as they present in clinical practice of the non-obstructive and the obstructive form. In the data published, if large registries, it's the obstructive, which is close to 70%, and close to 30% of the non-obstructive form. And the symptoms can be common to both of these forms in terms of dyspnea, fatigue, chest pain, palpitations, and syncope. The treatment modalities available for each of them vary slightly in terms of the underlying pathophysiology. As you can see, beta blockers and calcium channel blockers with the addition of disopyramide may have to be brought in to medically manage the obstructive form. And of course, we have the new agent mavacamten, which has now come onto the scene. And of course, patients with obstructive form with refractory symptoms would need advanced therapy in the form of myectomy, septal ablation, and of course, advanced forms of transplantation in both subsets if they proceed to end-stage heart failure. So coming to the topic at hand, so the combination of pregnancy, in the context of pregnancy, hypertrophic cardiomyopathy, we face unique challenges, and this brings into focus the physiologic changes which are related to the intersection of pregnancy with hypertrophic cardiomyopathy. So if you look at some of the physiological changes which occur in pregnancy in the antepartum, peripartum, and postpartum phase, you can see in the antepartum there's a rise in cardiac output and heart rate with an increase in the LV cavity size, increased blood volume, the systemic vascular resistance, and the blood pressure falls. In the peripartum phase, you can see that the increased cardiac output and heart rate maintains to be high, and the LV cavity blood volume is also high. The systemic vascular resistance may show an upward trend, and the blood pressure may show an upward trend. In the postpartum phase, the increased cardiac output from baseline and heart rate shows a downward trend, and with the LV cavity and blood volume also tracking the same. And in this situation, you may have the systemic vascular resistance and blood pressure increase. So all of these changes are quite important as we try to interpret its interaction with the pathophysiology of hypertrophic cardiomyopathy. So in essence, on the right-hand side, as you can see, in HCM pathophysiology, you have the markers of, it could be a dynamic LVOT obstruction. And of course, we know that there is significant diastolic restriction, diastolic dysfunction in these patients. On the background of these markers of HCM pathophysiology, if you have systemic vasodilatation, it could probably worsen LVOT obstruction. Increased plasma volume could also lead to heart failure exacerbation in these patients, in the pregnant patient. An increase in heart rate itself can probably worsen the gradients, or it can reduce the diastolic filling time, and we know this could itself contribute to LA hypertension and heart failure exacerbation. And there are certain hormonal changes in pregnancy which may be conducive to an increased expression of arrhythmias such as atrial fibrillation or ventricular tachycardia, atrial fibrillation bringing with it the increased risk of stroke. Not only atrial fibrillation, but the prothrombotic tendency of the pregnant status itself, adding on to the thrombotic risk in this case, and of course ventricular tachycardia always raising the specter of a sudden cardiac death event. So what is the overall risk associated with the pregnancy in HCM? And I think this is a very interesting evolution of data. If you dial back the clock to 2002, this is one of the earlier data sets which was published from the Italian group, which looked at 91 HCM families which included 100 HCM women, and they looked at 199 pregnancies in HCM women. You could see that 98 patients survived pregnancy, and there were only 2 maternal deaths, and this was led to an estimate of a maternal mortality rate of 10 in 1,000 live births. So this is a very old data set, and this is early 2002, and the 2 maternal deaths, one was a patient with severe LVOT obstruction with gradient as much as 110 millimeters of mercury, and the other patient was having a strong history of sudden cardiac death, 5 members of the family with SCD, the patient herself succumbing to sudden cardiac death. But fast forward from 2002 to 2017, and this is one of the data sets which is often quoted now, and this is the ROPAC registry from the European group, where they looked at 60 patients with hypertrophic cardiomyopathy, pregnant patients with hypertrophic cardiomyopathy. And the key highlights are the following. There was no maternal mortality per se attributable to HCM in this analysis. However, 23% of patients did experience at least one major adverse cardiovascular event, which could have included either death, heart failure, hospitalization, arrhythmia, or thromboembolism. 15% suffered from heart failure syndrome. 12% had an arrhythmic burden, which was, if you look at the breakup, it's about 10% of ventricular arrhythmias and about 2% of atrial fibrillation, 5% fetal loss. And most of these events, they happened in the 3rd trimester and the postpartum period, which was identified as the most vulnerable period. The strongest predictor of MACE was an NYHA class, pre-existing NYHA class of more than or equal to 2, or heart failure symptoms before pregnancy. And the outcomes between obstructive and the non-obstructive forms were not any different. Now, this is an older study, 2014, but this is very important because most of the guidelines which were published, in fact, relied on this study, the study by Schinkel et al. This is in 2014. This is because it looked at 408 pregnancies, and the key highlights were that the maternal mortality rate was about 0.5% and a 29% MACE rate, which included angina of 10%, dyspnea in 17% of patients, and heart failure in 11% of patients. And if you look at the arrhythmic burden, the ventricular arrhythmic burden was around close to 5%, and the supraventricular burden was around 7%. And the preterm birth rate was elevated significantly, 26%, but the spontaneous abortion and stillbirths were comparable to the general population. Now, the key question is, would this data reflect contemporary care now? And the answer is probably no, for a couple of reasons. One, this is a single author study, and in fact, the systematic review criteria by the Cochrane database, it's not sufficiently fulfill the criteria now for a systematic review to be published, number one. Number two, most of these patients, more than half of these pregnancies happened before the year 2000. So hence it's a different era. It's not an era of contemporary management, and therefore this would not probably reflect the contemporary data that we have. And more than that, close to 1,000 patients' data in terms of pregnancy in HCM was published after this study, which should give us a more contemporary look at the data of HCM and pregnancy. So that's why this is a very recent systematic review published in the International Journal of Cardiology, 2022, and one would be hard pressed to look at a more contemporary account than this. So if you look at this, it was looked at 1,624 pregnancies. So we have a lot of data now, and as you can see here, the maternal death rates approximately approached 185 maternal deaths per 100,000 pregnancies. The arrhythmic burden to the tune of 1% for ventricular arrhythmias and 4% for atrial fibrillation, 9% in prevalence of syncope. There was a 14% rate of cesarean sections, and that was for hardcore CV indications. Postpartum hemorrhage was around 3%, preeclampsia 4%, and heart failure 5%. In terms of fetal outcomes, there were 2 neonatal deaths per 1,000 births, 22% preterm birth rate, and 1% stillbirth. Now, to put this data into context, if you look at the maternal death rate in this data, it's about 0.18%. And if you compare it with the national mortality rate of the United States, it's about 0.0174%. So does it really mean that the odds of dying in a patient with HCM in pregnancy is close to tenfold? Probably not, because this cohort is in fact coming from not from the general population cohort, but it's a referral cohort from certain centers, so it might not be representative of the general cohort. In that, and there's also the issue of a length time bias, because this meta-analysis in the systematic review included earlier cohorts and contemporary cohorts, and the patients belonging to the earlier cohorts may have had a worse outcome as compared to the contemporary cohort. So due to these two factors, even the 10% rate might be an overestimate, and probably we need longer data sets to probably arrive at a much more accurate characterization. So what can we conclude in terms of consensus on risk? So most patients with HCM would be characterized by the modified WHO classification as 2 to 3 class risk. This translates into a maternal cardiac event rate of around 19 to 27%. Amongst these patients, there are certain very high risk markers such as LV systolic dysfunction or a severe LVOT obstruction, which would confer a higher risk of class 4. For patients who are class 3 or higher, they need to be looked at very closely in a multidisciplinary team, and the need for pre-pregnancy counseling and individualized care is all the more important. A bi-monthly follow-up in such a unit is generally advised for these patients, and if it's mild disease, a follow-up visit every trimester would be the recommendation. I'll just move to the last section of my presentation, which is just look at certain key management perspectives in HCM in pregnancy. So if you look at the heart failure complex, heart failure subset, either in non-obstructive or obstructive form, one has to be very careful with diuretic therapy, because we have to remember we are dealing with a hypertrophied heart, a small cavity heart, which is preload dependent for stroke volume. So even if the patient has congestive symptoms, I think we have to use just the right amount of loop diuretics to relieve congestion and not to compromise the sensitive hemodynamics in the situation. Thiazides are not generally preferred, but they seem to cause thrombocytopenia in the mother and the child. Mineralocorticoids are not encouraged because of its anti-androgenic effects, and ACE inhibitors, of course, are teratogenic. If one needs to reduce the afterload, let's say in preeclampsia or eclampsia, labetalol or hydralazine are often encouraged, but then one has to be careful with their use. In terms of ventricular tachyarrhythmias, lidocaine and sotalol, mexaltine are considered alternatives, interchangeable alternatives to treat these patients. Sotalol is extensively secreted in breast milk, so one has to be cautious when using sotalol. Amiodarone is considered to be the last choice when the other agents are not effective, for the simple reason that it can cause significant toxicity for the fetus, congenital goiter, and it's excreted in the breast milks even weeks after it is stopped. In terms of atrial fibrillation, I think we all know that the importance of retaining sinus rhythm is very important, because the atrial kick contributes to a significant degree of cardiac output in these patients, and sotalol, flecainide are all options which one can use in these patients cautiously if the benefits are considered to be more than the risks. Amiodarone and dofetilide are not considered. The data still, for safety data, is not very encouraging for these two agents. Beta blockers in terms of rate control are quite acceptable. Atenolol is a red flag. It's not encouraged. It is class D because it's extensively secreted in the breast milk, and it's also caused significant IUGR, fetal bradycardia, and hypoglycemia. Anticoagulation is mandatory. We know that the stroke rates in atrial fibrillation and HCM are quite high, and vitamin K antagonists, they can be used in the first trimester if the cumulative dose, you can bring it less than 5 milligrams per day. Otherwise, the logical choice, if the dose exceeds, the logical choice would be to shift over to low molecular weight heparin. DOAC, there is little evidence in use in pregnancy. In fact, there's a small study which was published 2 years ago, in which 37 pregnant women were inadvertently exposed to rivaroxaban, and out of the 37 patients, 6 patients had spontaneous abortion. So there's a definite red flag there, and currently we do not have evidence to use these agents in pregnancy. A small note on disopyramide: if the pregnant patient has severe left ventricular outflow tract obstruction, for symptom relief, one can use disopyramide safely in pregnancy, but a word of caution: it can sometimes precipitate uterine contractions, and of course, it's secreted in breast milk, so one has to look at anticholinergic effects in the child also. The standard resuscitation measures, the cardioversion measures, treatment for ventricular tachycardia and supraventricular tachycardia, all these principles hold good for patients, pregnant patient with HCM. This slide is not particular for patients with HCM. So essentially this slide is for a broad-based population with heart disease in pregnancy. So resuscitation, cardioversion, antiarrhythmic drug use for ventricular tachycardia, and SVTs. The general principles will hold for even in HCM patients with pregnancy, and hence the standard indications hold good. So if for a larger perspective, if you zoom out and you look at the larger perspective, at each phase of the physiological changes that one encounters in the antepartum, peripartum, and postpartum phase, at each stage one can sort of closely look at the patient, a multidisciplinary unit, a close echo assessment, probably investigate in terms of ambulatory monitoring when the patient presents with palpitations, beta blockers for LVOTO or arrhythmias, and of course, as I mentioned, cautious use of diuretics. A vaginal delivery, unless otherwise indicated for obstetric concerns. The other concern is during C-section, a single shot spinal anesthesia is generally not advised because a rapid drop in preload can play havoc with hemodynamics. So either it's a slow epidural anesthesia or general anesthesia, which is often well tolerated. And of course, the other usual medications are resumed once the patient moves into the postpartum phase, and of course, to diurese as needed. As needed is as a key word here, and not to over diurese. So in summary, in HCM pregnancy, what do we know now by looking at all the decades of data that we have analyzed? We can be fairly sure in recommending to the patient and the family that women with HCM can be reassured when considering pregnancy that the actual risk of maternal death, stillbirth, or neonatal demise are low. And we have a whole lot of data to look at. But having said that, pregnancy is still marked by an elevated risk of several cardiovascular and obstetric complications, and every patient needs to be individualized. There is no one-size-fits-all approach when it comes to HCM and pregnancy. We also know from all the decades of data that the majority of adverse events, they happen in the third trimester, in the postpartum period, thereby identifying a vulnerable period in pregnancy. And in terms of guideline recommendations, both societies recommend that select women with HCM looking to become pregnant should receive a multidisciplinary care unit treatment, a multidisciplinary care unit approach with preconception counseling and risk assessment. Thank you for your patient listening.
Thank you, Dr. Ahmed. Dr. Raidu has a comment to make. Dr. Raidu.
Interesting case discussion. See, hypertrophic cardiomyopathy. Most of them who have severe degree of aortic obstruction will have symptoms before pregnancy. So it is the best time to treat them is before pregnancy itself, putting an IVCD. And patients who doesn't have any symptoms before pregnancy, in general, they tolerate the pregnancy because pregnancy pathophysiology is favorable for except third trimester and delivery. In general, patients who doesn't have symptoms before, probably your patient didn't have any symptoms before pregnancy, became symptomatic during pregnancy.
If the symptoms were secondary to left ventricular outflow tract obstruction, we definitely expect it to improve during pregnancy. But this patient had a clearly documented arrhythmia in the Holter with multiple runs of VT, which was unfortunately precipitated during her first trimester after confirmation of pregnancy. And hence we had to proceed with the ICD, especially when she is not willing to terminate the pregnancy.
My question is to Dr. Preetham.
Yes.
Could it have been just a supine syncope of pregnancy?
Sorry,
A supine syncope. Now, in pregnancy, there is one entity which is described not infrequent, is supine syncope because of the
IVC compression.
IVC.
Yeah, this is 10 weeks. It's unlikely that a gravid uterus of 10 weeks would.
Too early to have
Yes.
that. But did you consider that and put in different?
No, sir, a patient with HCM having syncope, having clearly documented arrhythmia, definitely would warrant an ICD. So Other possibilities still we kept in mind, but when there's a risk of sudden cardiac death, patient definitely requires an ICD and an early ICD, of course, in this patient.
Did you register the arrhythmia during syncope
No,
or just preceding or following?
we couldn't record any event before the syncope.
Okay. No, the non-use of radiation and then putting in the ICD is quite impressive by ultrasound guidance. That's what is a big take from your case. Would you have put the ICD anyway in this patient, even without pregnancy?
Yes, sir, definitely.
So there was an indication for ICD anyway.
As a primary prevention itself, she warrants an ICD. Considering VT, syncope, she warrants an ICD.
The extension of, our discussion is, did you do a fetal echo in the third trimester or end of second trimester, because the baby also may be having hypertrophic cardiomyopathy either during pregnancy or after delivery? Did you check for that?
No, she's still pregnant. This was done only.
So she hasn't delivered as
She hasn't delivered. We are serially following her up. She's doing fine.
fetal echo?
Fetal echo is still pending, sir. 24 weeks.
Sir, actually, she had. Sorry, sir. So this lady, it's not a primary prevention. She's had 2 times syncope, and it's a documented VT that she had, sir. So that's why she warranted an ICD.
Next, my question is to Dr. Ahmad. Is there any head-to-head comparison of normal pregnancies versus HCM pregnancy? Because most of the data which you had shown and published is about HCM pregnancies.
Yes.
But is there any, comparative data head-to-head during the same period, age matched, trimester matched, and everything else being more or less identical?
Yes, sir. I think, sir, if you look at some of the early data sets, I think the Italian data set, which the 2014 data set, in fact, they also had they had compared the event rates and the MACE event rates with a matched population, although it was a small group. So that particular study also did look at the event rates with a fairly matched group, non-HCM pregnant subset. But all the subsequent groups, which are data sets which came after that, which is the 2022 review and the 2017, did not really account for a matched group analysis.
Okay. That would be quite interesting, because I am following up over a period of time in the last 50 years or so about roughly 500 patients of hypertrophic cardiomyopathy, various types, not one group, all groups. And out of that, I don't have a published data, but roughly about 80 of them were women.
Okay.
Out of the out of 80, I remember roughly 8 to 10 went through the pregnancy, and the mortality rate in that group was 0%. In my group, it's not a published data, it's only an observational data.
Yes, sir.
So my advice to my patients during this discussion always is try to find it out before pregnancy, as Dr. Raidu pointed out, and control them and do whatever you want to do before pregnancy, and carry them through the pregnancy. And we advise them that the risk is less than 1%. We wouldn't say 0%, but we say that less than 1%, though my own patient data is 0%. I think it is very interesting, but one thing I am very impressed is the technology that is being used to implant the ICD. That is one new thing I would take into consideration. It was quite impressive. So congratulations.
Definitely.
We'll move on to
See, most of the patients Dr. Krishnarazu was treating probably, I presume, maybe on disopyramide. Disopyramide is one of the important drug he used to tell us, very effective in controlling arrhythmias and as well as LVOT obstruction in most of the HCM patients. Probably is it, sir?
I can't correlate, but it is true that I use extensively disopyramide in those obstructive, either at rest or on exertion. I think we need to move on because we are behind time. We have a red flag from the organizers. So Dr. Raidu will take over for the next presentation. Dr. Somraju has a comment to make.
Comment. Actually, I just wanted to know, the speakers and the panel can tell us, what is the optimal heart rate you think one should achieve in patient with hypertrophic cardiomyopathy with today's information available and recent publications available? Optimal heart rate.
Would you like to take the call? Optimal heart rate in cardiomyopathy during pregnancy, is that right?
Hypertrophic cardiomyopathy or diastolic
No,
dysfunction.
during pregnancy or otherwise?
Otherwise, or during pregnancy, both. Yeah, the reason why I asked is there is a recent publication and a recent study done showing the optimal heart rates have to be slightly on the higher side, not bradycardia, because they showed clearly that bradycardia increases diastolic dysfunction. Because you have more diastole, more filling of left ventricle. I thought we should keep that in mind. Thank you.
So we'll move on to the next presentation. Dr. Raidu will take over.
The next presenter is Dr. Monica Dillikar. She will be telling on mitral valve prolapse. A patient of 33 years, male patient with recurrent palpitations, frequent palpitations, and has a multiple episodes of syncope and documented non-sustained ventricular tachycardia. Very interesting case, probably. Dr. Dillikar.
Good morning, all. Respected Narasimhan sir, thank you very much for the opportunity. Coming to the clinical history and the case presentation, we present today a case of a 39 years male patient who had a history of dyspnea, exertion, and palpitations experiencing over the last few months. He was evaluated at the outside center at this local place and was diagnosed to have a severe MR. He was referred to the tertiary center for the further management. Upon his arrival at a place, this was the ECG, which was a predominantly sinus rhythm with a PVCs of the RBBB morphology. They were negative, they predominantly negative in the 1 and AVL and positive in AVR, the lead 3 and the AVF. On the echo, this was the echo which showed a myxomatous mitral valve with a bileaflet prolapse and the posterior leaflet being prolapsing to the higher degree. He had a severe anterior directed MR, and along with the myxomatous mitral valve and the bileaflet prolapse, he also had a mitral annular disjunction, which has been described as a systolic displacement or a systolic gap between the posterior mitral valve leaflet and the basal endocardium. The distance was measured to be around 0.9 centimeters. In the 4-chamber view, again we could see there was the prolapsing leaflets with the possibly extension of the disjunction on the lateral annulus. There was an anterior directed MR, severe MR, and this was a volumetric assessment of the MR with a pizza radius of 9, the vena contracta of 0.9, and a holosystolic MR on the color M mode propagation velocity. He also had a Pickel-Hobbe sign positive, which is basically described as a systolic velocity, the peak systolic velocity on the tissue annulus on the basal infilolateral lesion, and the systolic velocity of more than 16 is considered to be a positive Pickel-Hobbe. The strain analysis also confirmed the same findings where the basal infilolateral lesion, they demonstrated a exaggerated longitudinal deformation. Just to summarize on the echo, it was a myxomatous mitral valve with a bileaflet prolapse with the PML demonstrating the higher degree. He had a dilated LA and a LV, a good LV function of 65%, a severe MR, a mitral annular and possibly a tricuspid annular disjunction, and a Pickel-Hobbe sign positive. Coming briefly on the mitral valve prolapse. The mitral valve prolapse, it is described as the superior displacement of the mitral wall leaflets of more than 2 millimeters above the mitral annulus during the systole, along with the myxomatous degeneration of the mitral wall leaflets with a maximal thickness of at least 5 millimeters during the diastole. There are basically two main etiologies of the mitral valve prolapse, the Barlow's and the fibroelastic deficiency. The Pickel-Haube, as described before, we have it is a peak systolic velocity on the lateral mitral annulus, the tissue Doppler, with a systolic velocity more than 16 centimeters, considering to be a positive. It is considered to be a risk marker for the malignant arrhythmias in the patients with the MVP. It is basically considered because it is considered to be happening because of the tugging of the posterior medial papillary muscles by the prolapsing myxomatous mitral wall leaflet. Talking very briefly on the disjunction, it is defined as the abnormal insertion of the flexion line of the mitral annulus in the atrial wall. It is a systolic separation between the ventricular myocardium and the mitral annulus supporting the posterior mitral wall leaflet, and is diagnosed in the transthoracic imaging, the parasternal long axis view. It is measured at the distance from the junction of the mitral wall leaflet and the left atrial wall to the base of the left ventricular wall during the end systole. So this is a pictorial depiction of the normal mitral annulus, which basically consists of the four components: the leaflet, the atrial wall, the crest of the endocardium, and the surrounding epicardial tissue. It is glued, or it is attached together with a fibrous cord. In the patient with the disjunction, there is an abnormal insertion of the mitral wall leaflet on the higher on the atrial wall. So there is a systolic gap. There is a systolic gap between the crest of the the crest of the left ventricle and the leaflet. This is very well demonstrated in this picture also, which is the plaques view. In the literature, there are basically three types of junction which have been described. The type 1 being there is no distance of the gap between the mitral wall junction. Only hypermobility is described. The type 2 being less than 5 millimeters of the disjunction, and type 3 being more than 5 millimeters of the disjunction. In the patients with the MVP and the disjunction, there could be a small percentage of the population who could also have a tricuspid annular disjunction. Vijay sir. Okay.
I think there is a talk on disjunction.
So
Probably
I guess sure.
maybe we'll have questions on that after the lecture is over. That point, if you want to show, you can. Next. Lecture.
Next, Dr. Vijay Shekhar from Apollo Hospital, Trichy, will be telling us about mitral annular disjunction approach and management.
A very warm good morning to respected teachers, senior faculty members and delegates. So in continuation with the case that was presented in the previous session, so this is about the approach and management of mitral annular disjunction syndrome. So this we know mitral valve prolapse, the definition I think was highlighted by the previous speaker. So by and large mitral valve prolapse, we always connect it with mitral regurgitation, and that leads on to hemodynamic consequences like LV dilatation, LV dysfunction and so on. So in the absence of a significant mitral regurgitation, mitral valve prolapse is generally believed to be a benign condition. And the overall survival of patients with mitral valve prolapse in the absence of severe MR is almost as good as those with the general population. But all said and done, there is a very small proportion of patients who are at a higher risk of developing ventricular arrhythmias and even sudden cardiac death. And this is the subset of patients that are labeled as either malignant MVP or arrhythmic MVP, and the risk of sudden cardiac death in these subgroup of patients or overall in the MVP subset is 0.2 to 0.4% per year. So what connects mitral valve prolapse and the risk of ventricular arrhythmias and sudden death? Are we missing something in MVP patients is what we are going to look at. So this malignant arrhythmic MVP, this is a retrospective analysis that was published in Circulation. What they found was like patients with a mitral valve prolapse and a documented ventricular arrhythmia and sudden cardiac death. So they tried to identify which subgroup of patients had this higher risk, and they found these four features. Patients who were females, they had a higher risk of SCD and a bileaflet myxomatous degeneration like the case that was shown here, and ECG repolarization abnormalities in the form of T-wave inversions in the infralateral leads. And again, if there are complex arrhythmias like presence of VPCs, they have a higher risk. So then what connects these patients like MVP to progress to arrhythmic MVP, what connects or what links the pathogenesis is whether there is a possibility of mitral annular disjunction being the connect between benign MVP and the arrhythmic MVP is what we are going to look at. So what is mitral annular disjunction? I think the definition has been previously discussed. So it is just the displacement of the point of insertion of the posterior mitral leaflet. So the mitral annulus has the anterior and posterior connections, where the anteriorly it is limited by the aortomitral continuity. So only posteriorly it has the annulus to attach, and when that gets spatially displaced towards the atrium, that condition is what we call as the mitral annular disjunction. So this abnormality was noted even as early as 1980s, but it was just considered as a very benign condition, just as an anatomic variant. But then later on studies published show that in patients with MVP, the prevalence of this mitral annular disjunction is as high as 20 to 58%. That is, almost every alternate patient with an MVP has some degree of mitral annular disjunction. So how to identify mitral annular disjunction? One is the echo parameters that already madam has highlighted. So usually it is in the parasternal long axis view. So this is just to highlight how a patient with a mitral annular disjunction will look. The scheme on the left shows that there is a distinct gap between the ventricular myocardium and the point of insertion of the posterior mitral leaflet. Whereas in a patient without a mitral annular disjunction but still with MVP, you can see during the systole there is definitely no gap. So echo forms the screening basis for identifying a mitral annular disjunction, and this is a video clip showing that there is a distinct curling motion of the basolateral LV. So you can see the LV infralateral portion or the posterolateral portion of the LV having a curling motion. That is again very a distinctive feature of identifying mitral annular disjunction. The other way you can confirm it is in a cardiac MRI. Cardiac MRI, again, the same factors that were demonstrated on the echo can be demonstrated on the MRI as well. Here we can quantify the mitral annular disjunction by two parameters. The longitudinal mitral annular disjunction, that is the distance, how much it gets separated from the point of insertion and ventricular myocardium. And this is a very important parameter because the longer the distance, the greater is the arrhythmic risk. And then circumferential mitral annular disjunction can also be quantified and measured in the MRI. Now we know how to identify the mitral annular disjunction in patients with MVP. Now how is it going to change the way we are going to look at this patient? Is now this article published in JACC took 116 patients with mitral annular disjunction proven on echo, and 62 of them even underwent cardiac MRI. And they found that they looked at arrhythmic events in these patients, and it was found that significant number of patients experienced a severe arrhythmic event. That is, among the 116 patients, 14 of them, that is at least 12% of them had experienced a severe arrhythmic event. So when they looked at further analysis of these data, so mitral annular disjunction can be associated with MVP, and it can be present even in the absence of mitral valve prolapse also. So among these 116 patients, 78 of them, 78% of them had an associated mitral valve prolapse, and 26 of them did not have a mitral valve prolapse. But irrespective of whether the patient had a mitral valve prolapse or not, the arrhythmic risk remained the same. So independent of associated MVP, it was the mitral annular disjunction that led to the increased arrhythmic risk rather than the MVP itself. So now we are able to find the missing link, what causes the increased arrhythmic risk. And when they tried to look at these patients and identify what causes the increased arrhythmic risk, they found two characters in the MRI that was associated with an increased ventricular arrhythmias. One is the longitudinal MAD distance, that is the distance of separation of the ventricular myocardium and the point of insertion of the posterior mitral leaflet. And if the patient had significant fibrosis that was demonstrated in the LGE, then these are the two factors that tells you that this patient could have a severe arrhythmic event. So this is from one of our own patients. You can see the left frame, the patient has a mitral valve prolapse. So this is a patient with mitral valve prolapse. And then you can see that there is a separation between the myocardium and the insertion point, and that is measured at around 7 millimeter in this patient. And again, there is LGE along the posterolateral aspect of the ventricle. So these are the two factors that will tell you that this patient might be at an increased risk of arrhythmia. So it has been again proven in other studies also that these patients with MVP and mitral annular disjunction, they have increased scarring, especially involving the papillary muscles as well as the infrabasal aspect of the LV. So this is again a histological correlation. The one on the left panel is a normal patient. You can see that there is no fibrosis at all. And in patients with the mitral annular disjunction, you can see that there are areas of fibrosis. That is, the bluish stained regions represent the areas of fibrosis. So you can see along the point of insertion as well as along the adjoining wall of the left ventricle, there is fibrosis. So how does this contribute to the pathogenesis? So if whenever there is a mitral annular disjunction, that creates an increased stretch or friction on the region where it is getting attached, and this results in fibrosis in this region, and this fibrosis contributes to the ventricular arrhythmias as well as the Purkinje fiber ectopy. So again, this has been clinically validated also. They have found that in patients with MVP, the VPC burden may vary somewhere between 50 to 85%. And most of these VPCs morphology, when they studied, they could localize it to the region of the posterobasal LV or the papillary muscle or to the fascicular region. So these can be some of the morphologies. The one that madam showed typically is from the region where the scar was found. And again, these can be multiple morphologies. Usually these are right bundle branch morphology, and they typically arise from the posterobasal or the infrabasal region of the LV. So to put it everything into a nutshell, so if you find a patient with a classical MVP, and then if the ECG, resting ECG shows some repolarization abnormalities in the form of T-wave inversions, and if you have a documented ventricular premature complexes or even non-sustained VTs or ventricular tachycardias, look for always associated mitral annular disjunction on the echo, and also look for scarring on the infrabasal LV as well as on the papillary muscles. So this subset of patients is what we are looking at as an increased risk of having a sudden cardiac death. So how do we manage these patients? Now that we have identified these patients, how do we manage these patients? So there is a consensus document that is been published in the EHRA. There are no recommended guidelines, but to classify as a patient having a high or intermediate risk arrhythmia, if the patient has any of these factors, the patient has a sustained VT, a spontaneous polymorphic non-sustained VT, a very rapid NSVT or polymorphic VPCs, or high frequency of VPCs, then these are the patients that we have to be extremely vigilant and offer more aggressive therapy. So in terms of therapy, we have medical treatment, catheter ablation, role of ICD and surgery. So these are some of the high risk NSVTs that can be picked up on a Holter. We can see that again the morphology is of right bundle branch, and here it is polymorphic and very fast non-sustained VT runs are being documented. When it comes to medical management, it is not any different from the VPC management for a general population. The usual goal is to reduce the VPC burden and attain an improvement in LV ejection fraction. Beta blockers, calcium channel blockers, and other antiarrhythmic drugs have role of reduction in VPC burden. Role of catheter ablation, again, long-term success in this subset of patients is between 60 to 84%. Generally, catheter ablation is reserved for patients in whom they are intolerant to drugs, or they become symptomatic despite drug treatment, or if the PVC is inducing a cardiomyopathy, or sometimes the Purkinje fiber ectopic can induce a VF. In these subset of patients, catheter ablation is indicated. Catheter ablation can be challenging in this subset of patients for the reason because the origin of the VPCs is very close to the papillary muscles. Getting ideal contact is this site can be really challenging. So the use of intracardiac echo as well as contact force catheters are recommended to achieve good success rates in this subset of patients. So this is one of our own patient where you can see the catheter is sitting. This is a nice image. The catheter sitting at the base of the papillary muscle, and you can see during ablation the VPCs, which was initially in a bigeminal rhythm, then gets terminated off. The role of ICD is not well defined in these patients. Of course, for secondary prevention, it is recommended any patient who has had an aborted sudden cardiac death or a VTVF, documented VTVF, is warrants an ICD. But for primary prevention, the guidelines are not still very clear. So whether surgery can eliminate, because this is primarily a pathology of the involving the mitral valve, can surgery eliminate the risk of arrhythmic risk in these patients? There are only sporadic case reports. This is one such case report where the patient again had the typical morphology of VPCs resulting in NSVTs and VTs. So this is a short story of the patient where she presented with a resuscitated cardiac arrest, detected to have moderate to severe MR and frequent VPCs, and initially was started on metoprolol. The entire subset fitted into the category of this malignant MVP. There was patchy fibrosis on the MRI. Patient was given an ICD, in spite of which patient was receiving ICD shocks, underwent a mitral valve surgery, and 3 years later the patient had complete elimination of symptoms. But again, this is just a case report. We don't have enough evidence to support that in all cases that surgery will cure the patient of the arrhythmia as well. Some of them, if they have an indication for mitral valve replacement for severe mitral regurgitation, they have done an associated cryo during the procedure, which again decreases the risk of arrhythmias. So this is the EHRA consensus document, which tries to kind of, it's not recommendations, I mean it's expert consensus document. What it tells you is to look at the symptoms of the patient, and if you find high risk features like what has been discussed previously, high risk arrhythmias, then the patient should be aggressively managed either with medical therapy, catheter ablation, ICD, or surgery. So in a nutshell, in a patients with MVP, like the patient that had been projected earlier, the lessons from this is that to look beyond MR. Always we have a tendency in a patient with the MVP is to look for only for mitral regurgitation, what is the severity and so on. So to look beyond MR that this patient could have a potential arrhythmic risk is what we want to emphasize. So be alerted if the patient has any symptoms of palpitations, pre-syncope or syncope, or if the ECG shows some repolarization abnormalities or typical VPCs of the right bundle branch morphology. So screen all MVP patients for associated mitral annular disjunction, and if there is a doubt, always confirm with an MRI, and in MRI look for the late gadolinium enhancement involving the infrabasal wall, and screen for high risk arrhythmias with extended monitoring using Holter or even ILR. So why these are important is that when you look for a patient with MVP with all these features, you are probably potentially preventing a patient who can have a sudden cardiac death. Thank you.
Thank you, Dr. Vijay Shankar. See, this is a very interesting and good discussion about mitral valve prolapse and mitral valve annular disjunction. See, mitral valve prolapse is most often is a very common problem. It is a broad spectrum of disease. See, from a benign disease to what you are discussing is extreme cases of mitral valve prolapses with severe regurgitation, mitral valve annular disjunction. See, my one question is that the surgery the patient underwent is valve replacement or quadrangular resection?
Valve replacement only, sir. That was actually a case report, so it was not done in our center.
Yeah,
it was
probably valve replacement will include the mitral valve disjunction involvement, I mean suturing also probably. And the common another cause of arrhythmias in mitral valve prolapse is they will have more bypass tracts. So they are more prone for atrial fibrillation and ventricular arrhythmias. There is another common cause. Because of the time limits, you have comment by Dr. Sastry.
not a comment, question. Did I hear you correctly that MAD can occur without MVP?
Yes, sir.
So in that case, the screening population should be those with multiple PVCs than mitral valve prolapse. Can I be
Both
wrong?
ways, sir. If the patient has a typical morphology that is suggestive of that it is arising from the region of the posterobasal LV or the papillary muscle, then those patients also should be screened for this, sir.
I think with that, we'll close the session.
Dr. Vasant Kumar is online. You have any comments to make, sir?
So nothing, sir. I'm waiting for the next.
Sure, thanks. So we are running behind schedule by 20 minutes. We'll have a quick 5 minutes tea break and rejoin for the next session.
Before
Thank you.
giving a tea break, I thanks Dr. C. Narasimham for inviting me for this, and my respects to our professors and teachers, Krishnamuraju and Dr. Somaraju.
హిందీనా తెలుగునా? తెలుగు సార్. నా ప్రజెంట్ okay.
Yeah, they're gonna see some. You talk to them sometime. Yeah. Okay, yes.
वो भी जवान ऐसा ही है, इधर क्लासमेट है.
Welcome back. If people can join us, we'll get started with the next session. May I request the chairpersons for the next session, Dr. Vasanta Kumar, Dr. Meeraj Rao, and Dr. B. Srinivas, to come over and take over and conduct the next session, please. Dr. Vasanta Kumar is not able to join us in person, so he's joining us live from Kurnool. Thank you, Vasant.
Thank you, sir.
Dr. Raidu, did you forget your bag here? Hope there is no money in that. No. The professor, you take over. Please start. I think so. The doctors, no, this one, no, yeah. Yeah, okay. All right. Welcome back again. Thank you, Narasimhan. I've learned a thing or two after attending the session. And congrats, AIG. Wonderful auditorium. I think probably the best in the city, if not in the country. I don't know. Really lucky guys. Wonderful setting. I have with me Professor Srinivas. He has kindly allowed me to take over the podium first, because I am the person with most grey hair. I welcome Dr. Vijay Shekhar to give us a talk on recent advances in electrophysiology.
No, sir.
Yeah, did I make a mistake? Oh, yeah. I think they're all mixed up here. There are too many here. My apologies. Case presentation by Dr. Tahir Sheikh. Can I invite you, Dr. Tahir Sheikh?
Good morning to all of you. I am presenting a case of 75-year-old male patient, structurally normal heart, who had received a pacemaker, dual chamber pacemaker, for symptomatic complete heart block a couple of months back. Now, after that, he complained, or he came to us with frequent palpitations and with some shortness of breath on exertion. His basic lab reports, his X-ray chest, and his 2D echo were essentially normal. He came to us with this ECG. This ECG is showing the device is pacing at a rate of 100 beats per minute. And so far as the atrial events are concerned, it's not clear from this ECG whether they are sensed or paced. He also came to us with this Holter. This Holter was showing a clear A-pace, V-pace rhythm, and device was pacing at a rate more than 100 beats per minute. And particularly this part of the tracing was in the early hours of the morning. This was another tracing from the Holter. Here we see that initial part of the tracing. There is some, the heart rate, the device is pacing at a rate of around 70 beats per minute. Then there are some ectopics, and after that the device starts pacing at a much higher rate, more than 100 beats per minute. The device interrogation of this patient revealed normal parameters, lead parameters, LRL of 60 per minute, but he had 90% of A-paced events and 100% of V-pace. His heart rate histogram showed that despite having LRL of 60, his device was pacing at significantly higher levels than the base rate. intermittently going more than 100 beats per minute. We decreased the LRL to 40, but still the ECG was showed that the device was pacing at 70 beats per minute. So we had a patient who had received a dual chamber pacemaker, and his LRL being kept low at 60 beats per minute. His device was continuously pacing at rate significantly higher than the base rate and intermittently going more than 100 beats per minute. Having a relook at the device interrogation, this was a Sanju device, and the patient's AF suppression mode was kept on. This is the reason that the patient was in atrial pacing overdrive for more than 99% of the time. So we switched off this atrial AF suppression mode, did the device resetting, and then we took an ECG, so the device started pacing at the basic LRL. So in the present patient, despite the low LRL, the device kept pacing at a faster rate, intermittently going above 100, because AF suppression algorithm was on. As patient was having frequent APCs, the device was intermittently increasing the pacing overdrive rate frequently. So throughout 24 hours, he was in atrial pacing overdrive mode. After switching off the AF suppression algorithm, patient's symptoms improved significantly. So this atrial fibrillation AF suppression algorithm is an algorithm in the Sanju device, which when on makes pacing always above the intrinsic rhythm during rest, exercise, and recovery. This is the pictorial representation, graphical representation of the AF suppression algorithm. The patient's basic rate will always be lower, and the atria will always be pacing. So over a period of 16 cycles, the device, if senses two intrinsic P waves, it will increase the rate of pacing overdrive rate, and then keep pacing at the new rate. Again, for 16 cycles, if it senses two more P waves, it will again increase its overdrive rate. It will continue to do it till maximum sensor rate is reached, or it reaches a stage when it is not sensing any intrinsic P wave. So once it reaches that stage of that is not sensing a intrinsic P wave, it starts increasing its cycle length of the overdrive pacing, and the heart rate starts to come down. So if the patient's intrinsic rate or basic rate is below 60, the device will overdrive pace at 10 beats per minute more, and if it is more than 150 beats, then device will increase the pacing rate at 5 beats per minute, and between 60 and 150, it will be between 5 and 10 beats more than the intrinsic rate. These rates are not programmable, but what is programmable is the number of the cycles that device paces before looking into the P waves. So this is the chart. Basically, if the rate is 50, the device will start pacing at 60. So the device follows this chart. While during the rate recovery, if the overdrive rate was less than 100 per minute, there will be a 12 millisecond will be added to each cycle, and if the overdrive rate was more than 100, 8 milliseconds will be added to each cycle. So this will ensure a smooth recovery of the rate till it senses any intrinsic P wave, when the rate will start increasing again. So this slide basically demonstrates the AF suppression algorithm in operation. Here the device is overdriving the atria at a rate of 84 beats per minute. It senses two intrinsic P waves, and then increased its overdrive pacing rate from 84 to 93. It keeps pacing at 93 for 16 cycles, and it is not sensing any intrinsic P wave, so it goes into rate recovery. So it starts increasing its cycle length, and the rate comes back again to lower heart rate. I mean lower paced driving cycles. So this patient basically had an AF suppression mode on. We switched it off, and there was a marked improvement in the symptoms of the patient. But this algorithm is basically to prevent atrial fibrillation. But sometimes these rates are not tolerable by the patient. So this patient was also not tolerating these rates, so we had to switch this off. And he had some baseline ectopics for which some beta blockers were added, and he was fine after that.
Thank you, Dr. Tahir Sheikh, for a very nice, interesting case. Especially this case, the patient presented with history of palpitations after dual chamber pacemaker, and evaluation did not show any very high heart rates. Especially the patient had palpitations. Perhaps this is
yes, it was Holter showed intermittently it was going above 100.
Yeah, above 100, but it
100,
not very
110.
high rates, not in a very tachycardia zone. No, the rates are not. So what I'm trying to say is, perhaps we should have that index of suspicion that AF suppression may be the reason for this kind of symptomatic palpitations when the rates are not very high following. Is it like that? What is the message emanating from this case?
Message is that we had kept the AF suppression on to prevent AF. It was kept on to prevent AF. But
Yes.
the thing is that he was not. He had no documented AF. But the thing is that he was having. He was not tolerating this heart rate. That's why he was having palpitations.
Yes, ma'am.
Tahir, it was really good presentation. So the message here is implantation is not the end, it's the beginning. You should understand your devices very well. So it was just inadvertently kept on. This patient never had an AFib. So it's up to early morning, this patient's heart rate is 74. His early morning heart rate is going up to 125, 130. And it's going up to upper tracking rate of 130, which patient was not tolerating. So we should understand our devices very well. Thank you.
So should we by default switch it off that AF?
Yes. No, it's mean you should switch it on only if required. If the patient,
required,
in a
yeah.
particular patient,
Not
you
by
need not
default.
switch it on in all patients.
So now I request Dr. Kumar Narayanan from Medicover Hospital to deliver his talk on post-implant complications after PPI relevant to this particular case.
Dr. Vasant, you are online. Anytime you want to make a comment, please button. Thank you.
Good morning, and thanks very much to the organizers for the kind invitation. So picking up from the previous talk, I'm just going to try and give a broad overview on the potential issues which sometimes you can encounter after implanting a pacemaker. So I'm really going to focus more on those situations where you feel the device is not working properly, you suspect some kind of a device malfunction, or the patient is not doing well with your post implant. We are not going to focus on mechanical complications like bleeding or infection. Those are straightforward to diagnose. So when we encounter so-called problems after a pacemaker, it can be possibly device related. There is a problem with the hardware itself. It could be programming related, which was what was illustrated in the previous case, for example, where a potentially unwanted algorithm was switched on. It could be disease related. So the patient could be having, for example, underlying arrhythmias and may have nothing to do with your device function. Or it could be sometimes patient related. Maybe the patient is going to a high EMI zone, or you have things like Twiddler's syndrome, which are rather unusual. So our job is to look at all the parameters and sort out in which of these brackets is the issue falling, and then take corrective steps accordingly. This is very important because pacemakers have really evolved since the beginning, and now we have pacemakers with a lot of algorithms, a lot of programmable features, and at the end of all of that layers, you have to understand what the device is doing, why is it behaving in that manner. is the function appropriate according to what we have programmed? And we need to be, of course, aware what can be changed in the programming. There are some programmable features and some are not programmable. But then just because a feature is programmable doesn't mean you should go and meddle with it. You also have to make a decision of what should you really be changing in that particular case. Before we even turn to the programmer, the history and examination is very important. As was highlighted in the previous case, if you just look at that whole term, there are some heart rates of 100, as the chairperson correctly pointed out, you're going to say there is not much of tachycardia. But the patient is not happy. He says, I'm having palpitations, and that's important to keep in mind. That's when you go in, look for a problem, see what the symptoms are, and therefore you need to sort it out. It's good if you can know the implantation details, especially if it was done at another center. Did they have a problem with lead positioning? Was there a problem with getting an adequate P wave, R wave? Was there a problem with the threshold at implantation? All of these can help you understand the present scenario. Then it's also important to know, because now there are so many algorithms which differ a little bit from company to company. I call them individual device idiosyncrasies. So it's important to be aware of that and understand how a program works in one device versus another. And of course, the ECG is a very basic tool you need to have when interpreting a programming. And some of the cases you need X-ray or other imaging to understand what's going on. So the basic thing is, when you are looking to interpret the rhythm in the presence of a device, a pacemaker, it involves simultaneous correlation of your ECG, the electrogram which you're seeing from the device, and also the device markers, which tells you what the device is thinking in its mind. What does it think is going on at this point of time? So all of you are aware about the device markers, which are a series of annotations. It tells you, is it sensing, is it pacing, is it seeing an event in the refractory period, and so on. So let's go through a few illustrative cases. Obviously, it's not possible to cover the whole spectrum of complications, but I'm just going to try and see if I can illustrate a few points. So let's have another story of palpitations after a pacemaker implant, possibly a more common one. So a 65-year-old male implanted with a dual chamber pacemaker system for complete AV block, and now coming with recurrent palpitations. And this is the rhythm strip which you see, and as you can see on the left versus the right, you can see a tachycardia, then a little break, again a tachycardia. Difficult to see, but you can see on the top strip at least that these broad Curious complexes are actually paced complexes. And this is what was seen during a recording of the atrial threshold testing. And you can see here that there is a annotation which says A, which means it's for atrial pacing, and when it says P, it's for atrial sensing. So you can see that when the capture is lost during atrial testing, you then have spontaneous P waves, and then you can compare the left and right, you have the onset of the tachycardia with paced Curious complexes. So you have the onset of tachycardia with loss of atrial capture. The other important thing to note is that if you measure this V to A during the tachycardia is always stable and fixed, which shows that this P wave is really because of VA conduction. And this is not surprising, because we should always keep in mind that antegrade AV block does not preclude VA conduction, retrograde conduction. And this is an important thing to keep in mind, because many times people would think that, well, if the conduction is blocked one way, it cannot happen the other way. And the conduction tissues are very unique in that aspect, that they can have completely different properties in one direction versus the other. Therefore, if you see this, this is the classical appearance of a PMT or a pacemaker mediated tachycardia. And what is the mechanism of a PMT? It basically occurs whenever a V-paced event or otherwise a V event is able to conduct retrograde to the atrium, which then starts off an AV delay, results in ventricular pacing, which then again results in a retrograde P wave, and this continues as a endless loop. And this can be initiated in various ways. It can be initiated with an atrial premature beat, sometimes with a ventricular premature beat. And what is essentially there to prevent pacemaker mediated tachycardias is the post-ventricular atrial refractory period, or the PVAR, which is there in dual chamber pacemakers, which is a period of refractoriness in the atrial lead after every ventricular event, which then prevents these P waves from conducting and starting off this endless loop. So PMTs can be initiated by anything which alters the AV relation which is going on during pacing. It could be ventricular premature beats, atrial premature beats, and things like loss of atrial capture, atrial undersensing and oversensing. These have various different mechanisms in which they can perturb the AV relationship and start off a PMT. So the prevention is generally by having a sufficiently long PVAR. Most of the devices now thankfully incorporate automated algorithms which diagnose and take steps to terminate PMT. But still, even if you have such algorithms, recurrent episodes, even short-lived episodes, can be quite disturbing to the patient. So you need to see whenever you have this kind of a PMT episodes going on, you have to look at what is causing it, whether a simple PVARP extension would help, or whether there is some other fundamental issue like atrial undersensing or something which is going on which you need to take a corrective measure. So this is the automated algorithm at work where tracking from A to B is suspended for 1 beat and then the PMT is terminated. Let's look at another case where there is a 57-year-old male with a complete heart block. A permanent pacemaker implanted with a lower rate of triple DR with a low rate of 75 beats per minute. The next day after implantation, the patient complains of chest discomfort, feeling of palpitations, disturbing neck pulsations, and this is the ECG which you see. So you can just contrast it with the previous ECG. You can see here that there is A pace, V pace going on, and there is a rate of 75 beats per minute. And you contrast with this ECG. What you can notice is that now the P waves are all over the place. There is no systematic tracking going on, and you can see, however, that the ventricle is now being just paced at the rate of 75 beats per minute, which has been programmed. Now, a lot of the dual chamber pacemakers have atrial based rates. You have the atrial channel, which is following the lower rate, which is pacing at 75. Here you cannot see a regular P wave activity. P waves are coming haphazardly. There is no stable AV relationship, and you are having a ventricular pacing going on at 75 beats per minute. So whenever you see this, you suspect that there is some issue going on with the atrial lead. It's not capturing, neither does it seem to be appropriately sensing and tracking the events. So the first thing, of course, which you need to check is the atrial lead position, and a simple X-ray or a fluoroscopy will show you that the atrial lead is dislodged. So again, if you just go by basic rates alone and then don't pay careful attention to the ECG, this is a fairly straightforward thing, but a very quick glance without really looking at what's going on with the AV relationship may cause you to miss the issue. And also, again, important to pay attention to what's going on. The rate as such looks okay, but the patient is not happy. So after repositioning, of course, you are restoring the usual AV sequential pacing. Here's another case where there's a 64-year-old male with complete heart block implanted again with a dual chamber pacemaker, but he comes back down the line complaining of recurrent dizziness and loss of consciousness. And you find intermittently an ECG like this, where you have P waves without subsequent tracking and without any initiation of ventricular pacing. So here there is a complete failure of output. There are no ventricular pacing spikes being delivered at all. So what's happening in this case? So if there was a failure to capture, then there would be pacing spikes present, whereas here there is a complete failure of the device to give an output. And usually this kind of a situation should make you suspect that there is potentially some kind of an oversensing going on. Here the ventricular lead is probably seeing something else and it's not giving a pacing output at all. So here is the tracings from the device, and you can see here this kind of noise which is occurring intermittently on the ventricular channel. This is being sensed inappropriately as intrinsic events, and whenever the device senses this kind of a thing, it's obviously not going to give an output. And this kind of a characteristic very high frequency noise should make you suspect a conductor fracture. So here you can see that imaging can help you sometimes in seeing that there is a lead integrity which is lost at a particular point, and sometimes this may not be very evident on X-ray. You may have to do fluoroscopy with a magnified view, maybe in multiple views, to see this. Quickly, another case, a 73-year-old female with CRHT, moderate MR and severe TR, who underwent a dual chamber pacemaker for sick sinus syndrome, but subsequently when the patient came, she looks to be in permanent atrial fibrillation and had also undergone a device change recently, a PG change recently for battery ERI. And she came relatively asymptomatic, but this kind of ECG was seen. And also, when we looked at the device interrogation, it said that the ventricular auto capture is in high output mode, that is 5 volts at 1 milliseconds. So you can see these complexes here, where you can see that there are intrinsic QRS here, looking of a very small amplitude, and you can see these pacing spikes which are coming after that, or it's coming just within or at the end of the QRS complex. So again, this ECG tells you that the device is not seeing this, and the programming was VVIR with a lower rate of 60 beats per minute. So this again telling you, when you look at this ECG, that the device is not seeing these complexes, and it makes you suspect that there is ventricular undersensing going on, because if you just march out these spikes, so these spikes are of course capturing because there is no intrinsic activity. If you just march out these spikes, it's just coming steadily at 60 beats per minute, and the device doesn't care what's happening. It's almost like a VOO mode where there is no sensing going on, and this makes you suspect that there is undersensing going on. Again, you look at the X-ray, the device leads are in place. Of course, this is an old device, and the chances of lead dislodgement are extremely low. And then when we look at what's going on inside, we see that the programmed sensitivity for the ventricular lead is 2.8 millivolts. That means below 2.8, the device is not going to see any R wave. But the sensed R wave in the bipolar setting was only 2 millivolts. Possibly this patient, having been implanted on a background of rheumatic heart disease, there is potentially some scarring in the ventricle. For whatever reason, the R wave is very low, and there was ventricular undersensing. And you can see these beats, which are pseudo fusion, because the ventricular spike is essentially not capturing, and it's only the intrinsic beat. And the auto capture was on high because of undersensing, because of a lack of sensing the evoked response. So this again, you can see how we need to.
Kumar Narayanan, I think we are up for the time for the next
Just
case.
last 1 minute. So I'll just summarize by looking at the various problems which you can see. You can see a failure to pace where there is no pacing artifact, and you have to see whether it's a normal algorithm or an issue with oversensing. For example, there could be PVCs which are not well seen on the surface ECG, or there could be myopotential oversensing. The second issue could be failure to capture where the artifact is present. Again, you have to see if it's a lead dislodgement or a lead malfunction or other issues. Failure to sense, we already covered, or it could be oversensing, which we again covered with a few issues of lead fracture and other extraneous noise. And lastly, when we are looking at the lead status, the impedance value and the trend is important to see. If there is a lead fracture, suddenly the impedance will go up, but we need to be cautious, as shown in the one case, that the normal impedance doesn't really rule out the presence of a lead fracture. So I'll conclude with this, basically to say that in diagnosing pacemaker malfunction, we need to keep a good knowledge of the patient's underlying condition, the programmed parameters, and then carefully analyze both ECG as well as the program parameters and markers to come to a conclusion. Thank you very much.
Thank you very much, sir. There is an excellent, very lucid, practically oriented talk, which is relevant to the case, a very interesting case Dr. Tahir has presented. So what do you think are the most common causes for palpitations following a DDD placement in a patient?
I think the common causes which I have encountered few cases of pacemaker mediated tachycardia. Even though there are automated algorithms, sometimes even with short episodes, patient does feel symptomatic. Other common cause is the presence of underlying arrhythmias. Many of the patients have intermittent atrial high rate episodes, atrial fibrillation, and these do lead to palpitations, especially if the patient has only intermittent AV block. For example, they can have ventricular high rates despite these atrial, because of these atrial high rate episodes. Diaphragmatic stimulation, again, very briefly I had shown, is something which we may especially encounter in a CRT device if the LV lead is very close to a phrenic vein, and if the thresholds are high, sometimes you're forced to give high output. So there are some of the common things, I think, in palpitations.
I think there is some comment.
Very nice cases, sir. Just a small comment about the pacemaker mediated tachycardia. Despite newer algorithms, there are frequent episodes, or there even, especially in St. Jude, what I encounter, there are many patients who come with PMT. One of the very common reason is there is a rate responsive p-VAR. So even if those advanced algorithms are there, most of the devices come with the rate responsive p-VAR on. So unless you switch them off, they keep on giving you PMT recurrences, even if whatever lengthening you do in your manual setting.
Absolutely, very correct. And my usual response to patient having PMT is not only to extend the resting PVARP a little bit, but also to keep the rate responsive PVARP at low.
Dr. Vasant, do you want to say something?
Nothing, sir, nothing. Thank you.
I have a provocative question to Dr. Narasimhan. These days, the devices and machines are so intelligent. If we don't tinker with them, they generally go along well. I only worry about the routine things of infection, bleeding, and such things. What say you?
Yeah, thank you. That's partly right. And one of the reasons why we presented the case of AFib suppression algorithm, the companies come with algorithms saying that this is better, so on and so forth, without looking at the outcome data. So we have had several patients where this AFib algorithm, which is supposed to suppress the atrial fibrillation, was producing more problems. And the efficacy is very, very minimal. So the answer to your question, in a vast majority, yes, it helps. But there are occasional situations where you need to be aware of what the algorithm is doing so that you can turn it off.
So human intelligence should step in to correct the machine malfunction. In fact, the case which Dr. Tahir has presented has really impressed me very much, sir. That is a very enigmatic problem, looks like a conundrum, but the solution is very simple. Just switch off that AF suppression mode and everything is fine. Any other comments from the house?
No. One more question. Do you think in future this little bit of incorporation of AI into these devices would help us?
Yes, it will definitely improve the performance, because the AI is, as of now, it is going to look at what Kumar is doing, what Daljit is doing, what I'm doing. All the data comes in, and then it becomes a better neural network. It's like it is using the brains of the 1,000 people, cardiologists, who are programming the devices. And if it's appropriate, it will be a super brain. So it will definitely perform better. But intuitively, I think you will always have a human being who knows what the device is doing, has to be there at the end of the table to improve the outcome.
Thank you very much, sir. There is a very educative talk. We'll move on to the next case. The case will be presented by Dr. Neelakant Patil from AIG Hospital on a 55-year-old male with uncontrolled hypertension and pre-syncope.
Good morning. I'm presenting a short case, quite deviating from the current interesting topic of pacemaker and electrophysiology. It's not coming. We had this 65-year gentleman. He is one of my colleague cardiologist father-in-law. So then diabetic since 5 years, had known hypertension since 10 years, and was on regular treatment with telmisartan. So she once called me saying, sir, my father's BP is getting higher. Can you suggest something? I'm like, okay, tell me the story about what's happening. So he told the BP is around 170 by 100 and he's on telmisartan. Last 2 or 3 months he's following up with his cardiologist and neurologist. But his main issue was that he's getting giddiness. multiple episodes of giddiness, pre-syncope, and then he had some difficulty lifting in the hands. And this pre-syncope was getting worse with physical activities, showering, and lifting weights. So he was first seen by a neurologist, where few of them saw him, did a CT brain imaging, which was normal, underwent a brain MRI and MR angiogram, that was also normal. And when he was found to have high blood pressure, he was seen by a cardiologist, where we saw Holter, which did not say anything. So for the blood pressure, he was like started on treatment with telmisartan, then added on amlodipine. After a few days, the dose was further increased, and patient is like, I am getting worse with all these medications, still getting a lot of giddiness and not improving. So that's how he was. I received a call. So I'm like, let us see the clinic. Otherwise, on the phone, I can just increase the one more medication, add one more medication. Let us see him in the clinic. So he came in the clinic. While checking his blood pressure, I have this habit of taking a history, and then while he tells the story, we touch both of his feet to check for dorsal pedis, hold both the hands. I had some difficulty finding left pulse. And then other than that, nothing much. ECG echo was okay with slight elevated blood pressure. So this is one angiogram. Finally, we did an angiogram next day that gave us the explanation for all his symptoms and the diagnosis. You can see here he had a tight left subclavian stenosis. More interesting focus on the vertebral flow. The contrast goes up and immediately contrast is being cleared. That means the flow is from up downwards, and hence there is a clearance of contrast in the vertebral and dilution of contrast in the subclavian. So a classical image of subclavian steel, where he does any physical activity, the steel worsens, and that is causing global hypoperfusion by causing the steel. And when we try to control his blood pressure more by giving more drugs and lowering the blood pressure, say from 160 to 130, the upper arm BP will further fall, and that would increase the steel. So the drugs actually made him worse. And so one thing explained all his issues, and elevated blood pressure was actually a incidental finding. All the symptoms were caused by subclavian stenosis, like giddiness, left arm weakness, and because of his elevated blood pressure, we could find out that he had this subclavian stenosis. The next step is to plan treatment. Before treating, we did a renal angiogram also that showed some moderate disease in the left kidney. So final diagnosis was this mainly subclavian stenosis causing subclavian steel with uncontrolled hypertension. Now to plan treatment, in the same setting he wanted treatment for subclavian. So before we go ahead with before the angioplasty of subclavian, there were a few issues which we had to discuss. One was we end up stenting the subclavian and then end up finding a left main stenosis, because he already had multiple risk factors for coronary artery disease. So we had to define the coronaries. And there is a very high risk of occlusion of vertebral once we stent across. So we have to be sure that the other vertebral is dominant. So he had and then other options is this vertebral artery occlusion, the same. The consequence of vertebral artery occlusion, that you have to be sure that if this is occluded, the other vertebral is dominant. So he had a CT angiogram done one day before. So we called the radiologist to confirm that other three arteries supplying the circle of Willis are good. So both common category are good and the vertebral are actually right dominant. So we are okay if this artery closes also. Other is the risk of stroke. Now here the blood flow is from top down. So unlikely that a plaque will go and travel up. If we do a stenting across the subclavian, the issue is if we do only ballooning to subclavian and the flow improves, that can push a plaque in the vertebral. So we decided not to do a pre-dilatation but go directly with the stenting. We first defined the coronaries as discussed. He had some mild coronary artery disease. Finally crossed with the regular diagnostic JR and J-termo. We exchange, once we cross, we pass the JR into the left subclavian and exchange the termo with the implant extra shift to carry out the procedure. Sheaths to be used, the stent size decided was 7 by 7 mm, and that is compatible with a 7 French long sheath. So this is a shuttle sheath actually. Even with the longer sheath, the regular sheaths, these stents are not compatible. Shuttle sheaths are one of the sheaths which have a very good internal diameter. and you can do a simultaneous injection also while positioning the stent. So underwent the subclavian artery stenting. One more thing to remember in these stentings is type of arteries, like coronaries are muscular arteries, while these subclavian, renal, aorta, they are elastic arteries. So muscular arteries can tolerate a high pressure, 18 atmosphere, 20 atmosphere, but for renal or peripherals, be careful not to go above 12 and 14 atmospheres. After this, the chance of rupture becomes very high. So they don't tolerate high pressure very easily. And one more thing different here is, if it's in a peripheral angioplasty, it's not coronaries, so we don't try for perfection there. A slight amount of under expansion or slight cosmetically not looking good results are fine. So this was the subclavian artery stenting, and as expected, you can see the vertebral closed off. This was done around a month back, and now patient is on 2 antihypertensives, BP 140/80, with no giddiness and no presyncope, and is doing quite well. So to summarize, even in the today's era of all the investigations, physical examination, how much ever we tell and stress importance, it's still important, relevant, and subclavian still is not as uncommon. But yeah, for me, this is one of the few cases, not very common. And these symptoms can worsen by antihypertensive drugs. And while doing the subclavian stenosis or taking care of it, keep other issues in mind like coronaries, renal, stroke, and the vertebral dominance. Thank you.
Thank you, sir. That's a very interesting case. Dr. Vasant Kumar, would you like to make any comments?
In the importance of physical examination, checking the blood pressure and all, 3 or at least 3 limbs is essentially established in this case. Probably if you have taken a proper blood pressure examination, the other limb, the blood pressure must be high, and we are treating that way. And the symptom, history taking of giddiness on exertion re-establishes the subclavian seal syndrome in this patient. And suspecting some other causes, especially when you are untreatable hypertension, like obstructive sleep apnea, primary aldosterone in some cases, all these things needs to be addressed. Thank you, sir.
Actually, when I saw the pulses, there was slight less pulse left up upper limb, so difficult to find. The patient is like, sir, don't check pressure here. Doctors have told me that BP doesn't come properly here. So, like, his blood pressure was taken before in the left hand. They're like, BP doesn't come proper in this hand.
I think this case to me illustrates and underscores the importance of a thorough, systematic clinical examination, general physical examination. We should have, a patient should have an examined for all any discrepancy in all the pulses, and when the patient presents with presyncope and giddiness, it's mandatory we auscultate the neck vessels and subclavians for any bruise. I would be very much interested to have the comments from Dr. B.K. Sastry as well as Professor Krishnaraj Garu about this case. Sastry Garu, please. You please give your comments. Because patient even has the MR angiogram, which is again an imponderable that it has not shown any obstructive lesion in the vertebrals or subclavian. So these are very interesting issues here.
Thanks for asking me, but I don't have any specific comment. As emphasized physical examination, and yesterday somebody was mentioning Dr. Somraju's book. All of us have come up reading that books. So basically, the moment first you see the pulsations, especially atherosclerotic vascular disease doesn't confine only to coronaries. Most of us deal with coronaries, and it is mandatory to palpate all the 4 limbs for blood vessels and look for the carotid bruise, because the prognosis, yesterday even Tiny Nair was emphasizing the importance of ankle brachial index. So these are all basics. So once you make a diagnosis, the treatment becomes easy. Otherwise, giddiness, syncope in elderly person is always an enigma. Multiple causes will be there, and this is one important cause which we can't overlook. Thank you.
Thank you, sir.
Dr. Krishnaraj, that is me. I just have a couple of comments to make. One is that we haven't excluded a thoracic outlet syndrome. The subclavian artery stenosis is all right. You could have made the diagnosis by simply palpating the pulse. we always tell our students to examine and take blood pressure in both upper arms and in at least one lower. Right? Most people don't. Now, in fact, blood pressure itself is not recorded by any consultant.
Yes.
It is done by the assisting nurse or a PA or somebody outside, or sometimes even drivers and secretaries sitting outside with a digital digital BP app. That is one comment I would like to make. Two, the subclavian obstruction may not be the total diagnosis because there is no evidence of atherosclerosis elsewhere. So, how did you exclude a thoracic outlet syndrome, which could have been because of a, Skelenus-Santikos syndrome or clavicular compression of neurovascular bundle, the thoracic outlet, or sandwiching between the clavicle and the first rib? There are three types of thoracic outlet syndrome. They could compress nerve, they could compress vein, subclavian vein, they could compress artery, or two or three, all of them. That is not excluded.
Sir, he did have multiple risk factors for stenosis, diabetic since 5 years, hypertensive and a chronic smoker. He did have evidence of atherosclerosis. He had all the coronary artery calciums, all three were calcified with moderate lysis. Even the left renal artery was diseased. Second, the day I saw him, next day morning, we first did a CT angiogram, and then in the evening, afternoon, we did the angiogram. So CT angiogram did of the chest did not show any obvious thoracic abnormalities.
But none of them have ruled out thoracic outlet syndrome.
I guess not in a systematic manner. Yeah.
The thoracic outlet syndrome is not thought about by most cardiologists, right?
Yes.
Because many of the current generation of cardiologists have become cardiologists by birth. They have not gone through MBBS, internal medicine and cardiology. All right. The second thing is, though it is not directly relevant to your patient, if a patient also had left coronary system disease, if the surgeon puts a Lima graft, right, there will be coronary stent.
Yes.
We have seen at least half a dozen patients where years after coronary artery bypass surgery, they come back with angina. When you examine them, the subclavian ostial stenosis has progressed. So there is a coronary steal from the left coronary back into the through the Lima graft into subclavian. So there again, the treatment is very simple. You just open up the subclavian.
Yes, sir.
These are the two comments I would like to add.
Thank you, sir. Thank you very much. Thank you, Dr. Patil. That's a very interesting case. I request Dr. Venkat S. Ram from Apollo Hospital to deliver his talk on management of refractory hypertension.
Good morning, ladies and gentlemen. After 2 minutes, I would have said good afternoon. Greetings and best wishes to all of you. And I thank Dr. Narasimhan and the AIG academic section for asking me to interact with you this morning. And it's my privilege to come to this wonderful hospital and wonderful auditorium. So my best wishes to all of you. Dr. Narasimhan called me last month and asked me if I'm in town today. I said yes, and he wanted me to give a talk on resistant hypertension, the same talk I gave 4 years ago in Calcutta. This is what he said. I want you to give the same talk that you gave 4 years ago in Calcutta, and I accepted it on one condition, whether he could also freeze my age 4 years behind. And if he accepts that, I said I will accept it 4 years back. So ladies and gentlemen, I'll try to do my best to meet his and your expectations. My presentation will not have any direct bearing to a wonderful case that was presented earlier, because that's a very unusual type of a case he presented. But I'll talk about the type of patients that you and I see with so-called resistant hypertension. The problem with resistant hypertension is we don't know who is resistant to hypertension, because people don't take their medications regularly, they don't take it in proper dosage, etc. but we apply this very loosely as a clinician. When you see the same patient again and again with hypertension, we just call them as resistant hypertension because we are fed up with them. They keep on coming, we call them resistant hypertension. But to define resistant hypertension from textbook, which we really can't do it in clinical practice because blood pressure changes quite a bit. Resistant hypertension, according to the guidelines, is somebody who is requiring more than 3 antihypertensive drugs to achieve the goal blood pressure, or somebody is requiring more than 3 drugs to control the blood pressure. So that is the definition. But at the same time, this kind of a definition in day-to-day practice does not work well. People don't remember what they're taking, etc. But nevertheless, this is the definition of resistant hypertension according to the guidelines. Now, who is resistant in this instance? Is it the patient or the doctor? Sometimes as doctors, we are a little bit hesitant to increase the medications because the patients and their families are showing this long list of medicines the patient is taking. They're already alerting you not to increase the medicine. So sometimes we are reluctant to increase the medication because the patient is there, the attendant is there, and one of the family members is an IT person and he's already checking on you on his handphone, etc. So we have to use optimal doses of medicine. So ladies and gentlemen, one important message that I want to convey to young doctors here is try to use optimal dosage of the drug. I don't understand why they make amlodipine 2.5 milligram. I don't understand it. I don't understand why they make amlodipine 5 milligram. No study has shown these doses lower the blood pressure. I don't understand why they make 10 milligram of enalapril. I have no idea. I don't understand why they make metoprolol 25 milligram. None of these have been shown to lower the blood pressure. I don't understand why they make nebivolol 5 milligram. It should be 10 milligram or higher. So very important message. Please try to use the doses that have been shown to lower the blood pressure, but just to please the patients and their families, chota dose hai, I'm not giving you a high dose. These things will not work in real world. You have to confront it, direct and reduce the blood pressure. Usually all the guidelines recommend when you diagnose hypertension, which is every day, you should reach the goal blood pressure within 3 to 4 months of the diagnosis. Within 3 to 4 months of the diagnosis, that is when you have to reach the goal blood pressure. Therefore, you have to follow the patients closely. Now, what happens is most of the patients with hypertension end up requiring multiple medicines. This is a very beautiful study, all-hat study done in 40,000 patients. What it shows is all of them started on one drug, but the number of patients who were on one drug after 4 years is less, and the number of patients who are on 2 to 3 to 4 drugs increases. So ladies and gentlemen, all the patients might start with 1 or 2 drugs, but ultimately they end up on 3 or 4 medicines to control the blood pressure. Now what happens is sometimes patients will say, my blood pressure is high only in your office, it is not high outside. I went to a wedding reception last night, thoda kha liya. All these things they will tell you as if the blood pressure is high only in front of you. But actually many times patients who have white coat hypertension end up having regular hypertension anyway. So, but if the patient argues you with that much, if possible, you might want to get 24-hour ambulatory blood pressure. But the usual reason for so-called loosely applied definition of resistant hypertension is non-compliance or non-adherence to the treatment. Now, this I mentioned to you already that the doses that sometimes I see in the patient's records are really not the doses that should be used in clinical medicine. I'm not suggesting that you should give higher toxic doses. I'm not suggesting that, but try to use the drugs that have been recommended, but don't give very low doses just to please the patient. And the wrong type of a diuretic. Usually, let us say you start the patient is on a thiazide type of diuretic, and 3 hours later you see a patient with CKD who is stage 2 or stage 3. And in stage CKD, the thiazide diuretics do not work. You have to convert the patient to a loop diuretic. So change the type of the diuretic that you are using based upon the renal function. And sometimes the patients are taking over-the-counter medicines that increase the blood pressure, and sometimes your patient has seen a rheumatologist, and the rheumatologist has put the patient on high-dose steroids, and you would not know about it, and the rheumatologist did not tell the patient that steroids increase the blood pressure. So sometimes the patients, when they're seeing multiple doctors, some of the drugs that we give might increase the blood pressure. Keep it in mind. Now, if possible, ladies and gentlemen, I am not mandating it. I am not just crazy about ambulatory blood pressure monitoring, but if you have ambulatory blood pressure monitoring ability in patients with seemingly resistant hypertension, it's not a bad idea to get at least one time ambulatory blood pressure done. And this is a study where they showed the blood pressure in the office, and the same patients on 24-hour ambulatory blood pressure, the blood pressure is lower than what it was in the office. Now, Dr. Vasant Kumar commented on workup for primary hyperaldosteronism. A number of patients with resistant hypertension can have primary hyperaldosteronism. Not as high as shown on this slide, by the way. These are really exaggerated figures of patients with resistant patients having primary hyperaldosteronism. But if somebody has unprovoked hypokalemia, uncorrectable hypokalemia, unexplained hypokalemia, and hypertension, please think about primary hyperaldosteronism. Dr. Vasant Kumar also mentioned about obstructive sleep apnea in resistant hypertension. It is very, very clear that patients who have significant obstructive sleep apnea can have hypertension. This is a slide showing that episodes of apnea to hypopnea. As they increase obstructive sleep apnea, the blood pressure keeps on increasing. So an important cause of resistant hypertension, if you want to consider, is obstructive sleep apnea. The problem is when you give them on CPAP or home oxygen therapy, the compliance is not very good. And this is a study showing that what happens to the blood pressure in patients with obstructive sleep apnea when they have full therapeutic CPAP compared to subtherapeutic, suboptimal CPAP. You will see when you give proper CPAP and the patient is taking CPAP at least 6 to 8 hours every night, the blood pressure does come down. So one correctable cause of resistant hypertension based upon your clinical exam is to consider obstructive sleep apnea and see if oxygen therapy will improve it. That's all. Now, this is a very high incidence of obstructive sleep apnea and resistant hypertension, but just to make a point. Now, let me come to some management issues very, very quickly. I already mentioned to you about adherence is a problem in hypertension, no matter where the patient is. I also told you changing the diuretic based upon the kidney function and titrating the medications to the proper recommended doses. And you really don't have to do too much of a big workup on the first visit. Don't send the patient to renal Doppler. Don't send the patient to CT angiogram. Don't send the patient to metanephrine. Simple electrolytes, BU and creatinine, EKG, echocardiogram, urinalysis, protein. That's all is needed in the first visit. But don't bombard the patient with multiple investigations because they may not come back to you. Very simple. Importance of physical examination was already mentioned. Just a routine laboratory test, renal function, proteinuria, electrolytes, etc. That's all is needed. And I think, at least in Hyderabad, I don't think there is anybody who is walking around in Hyderabad who never had an echocardiogram. Everybody in Hyderabad has not only one, but multiple echocardiograms because every hospital wants repeated. So echocardiogram, every patient has it, no problem. I told you about ABPM already. Now, if you have a patient who is not on a diuretic and who has hypokalemia and hypertension, there is a very good chance the patient has hyperaldosteronism. And very simple thing, you don't have to do a big deal. ask the patient to come and measure aldosterone to renin ratio. If the aldosterone to renin ratio is more than 30, the patient is likely to have hyperaldosteronism. And based upon your clinical examination, you can get the rest of the workup later on. I'll show you some cases. I already mentioned to you, when you suspect obstructive sleep apnea, you can get a sleep study done. Now, just some lifestyle changes. We tell the patients to follow the lifestyle changes. You should just enforce as much as possible. You can't do anything more. You can just tell the patients about the weight, about the tobacco, about the salt. You emphasize them. Now, I want to mention about hypothyroidism and resistant hypertension. One of the important causes of resistant hypertension in clinical practice is uncorrected hypothyroidism. This is a slide showing systemic vascular resistance in patients with hypothyroidism, in patients with hypertension, and who have both. You will notice hypothyroidism and hypertension have one thing in common. Both the conditions elevate systemic vascular resistance, which is blood pressure. So, ladies and gentlemen, instead of subjecting the patient to too much of invasive tests, please order free T4 TSH, not T3, free T4 TSH in resistant hypertension, and it's a very cost-effective test. Not a problem. This is a study in patients with hypothyroidism and resistant hypertension, response to thyroid treatment, and response to antihypertensive drugs. Very, very simple. Now, I want to show you a couple of cases and then I'll conclude. Now, pharmacological treatment of resistant hypertension. Let us say you believe the patient, which is a good thing, by the way. Patient is taking the medications, which is a good thing. The patient has resistant hypertension on medicine. Think about adding aldosterone antagonist spironolactone if the patient has normal kidney function. This is a study showing response to spironolactone in patients with resistant hypertension. So one drug that you should keep in mind is adding an aldosterone antagonist, usually spironolactone. There are not many studies with eplerenone. Adding spironolactone 25, 50, 100 milligram could lower the blood pressure in resistant hypertension. Why? I don't know. But aldosterone antagonist is a good choice in patients with resistant hypertension. Now, secondary causes of hypertension based upon your clinical evaluation. On the basis of your clinical evaluation, consider secondary forms of hypertension. I'll show 2-3 cases, then I'll conclude. In young women with resistant hypertension, think about the possibility of renal artery stenosis, fibromuscular dysplasia, or Takayu's arteritis. Keep that in mind. You don't have to do the investigation same day, but keep that in mind and follow up. And this is a patient of mine seen at Apollo some time back. Patient had severe hypertension. You see how severe hypertension was. She had bilateral renal artery stenosis with fibromuscular dysplasia, and she underwent angioplasty. And you will see after angioplasty, the blood pressure became remarkably normal within 1 month. So one of the causes of resistant hypertension in suspected young women would be to suspect fibromuscular dysplasia, and there is good treatment for it, a very dramatic result. Now, if you have a patient who has low potassium and not on a diuretic, but low potassium, don't ignore it. Repeat it, and if it is still low, do the workup for primary hyperaldosteronism. This is another patient of mine from Apollo. Look at the potassium, 2.3. I want to make one comment here, Mr. Chairman, ladies and gentlemen. When the potassium is low, there should be a reason for it, right? There should be a reason for it. Don't ignore it and ask the patient to eat bananas, drink orange juice, drink apple juice. How many bananas patient can eat? Each 1 inch of banana has only 1 milli equivalent of potassium. So how much bananas you want the patient to eat, it will never replace. Banana and fruits are not for potassium replacement, they are potassium supplements. They will never correct hypokalemia. And this patient, poor patient, has been on bananas until she saw me. And these are her electrolytes. Look at her aldosterone. Look at her plasma renin. She has primary hyperaldosteronism. CT showed an adrenal tumor and it was removed. And look at the patient's blood pressure before and after. Look at the potassium before and after. This is a very classical example where hypokalemia should not be ignored. And this is from my previous experience before coming back to India. Patients that we have seen, almost 50 patients we had seen with primary hyperaldosteronism before and after treatment, before and after treatment. Now, Dr. Narasimhan is here. Some of you are also here. Renal denervation. मुझे renal denervation चाहिए. मैं wait कर रहा हूँ. मुझे चाहिए. Okay. These are couple of editorials I have written for leading journals. They wanted my comments on renal denervation therapy. So these are two editorials I have written recently for European Heart Journal. Renal denervation therapy for hypertension, all that glitters is not gold. So when I analyzed all the results, Dr. Narasimhan, with due respects, the effects of renal denervation were effects of one antihypertensive drug. So you give the choice to the patient. Either you take this extra pill or have your femoral puncture, one of the two. And the patient can make an informed choice depending on it. So listen, I'm not condemning it. Probably it works in some patients, but I don't think it can be applicable in large number because we don't know who is going to respond. At the present time, it requires femoral puncture. So let me conclude, Mr. Chairman, ladies and gentlemen. First, make sure that the patient is reasonably compliant. Nobody is 100% compliant, and patient is following a healthy diet as much as possible. Now, change the diuretic if needed based upon the renal function. Optimize the treatment, increase the medications. Don't worry about increasing the medications. And keep in mind these following drugs for adding on top of your usual drugs. One is, I mentioned to you, spironolactone. The other drugs, keep in mind, centrally acting drugs such as moxonidine should be added. Don't forget two old drugs, hydralazine and minoxidil. We tend to forget them. Keep in mind, aldosterone antagonist, centrally acting drugs, hydralazine, minoxidil as important pharmacological options to add to patients with severe and resistant hypertension. Very, very important to keep in mind. Now, ladies and gentlemen, you are the first audience to see the title of this paper, which was published this morning at 7:01 India time, 12:01 Central European time. There was an embargo until last night. I don't know what is not normal blood pressure, but we should always try to see what is optimal blood pressure. Optimal blood pressure, depending on the patient characteristic, that is what we need to wait and see. And there are some new guidelines that are going to come in June of this year. I don't know why we need more guidelines, to be honest with you. I think enough is enough. It doesn't mean anything. We don't need more apartments. We don't need more vehicles. So we don't need any more guidelines, but there is one more guideline that is going to come in June. I have an idea what they're going to say. But if you stick to some of the existing guidelines, that is good enough. That is good enough to follow. So, Mr. Chairman, ladies and gentlemen, in the time that was allocated to me, I just gave you some glimpses on approaches to resistant hypertension. This was not a tutorial on resistant hypertension, but certain aspects of resistant hypertension that you can think about when you see patients in your clinics on how to approach them, pharmacological treatment, how to work up and how to manage them. Importantly, to follow these patients, at least regularly you should follow them. Don't tell them Eid ke baad aao, Christmas ke baad aao, Ugadi ke baad aao, Ram Navami ke baad aao, holidays ke baad aao, Shadi ke baad aao, Mangni ke baad aao. these things won't help at all. Try to see the patients like oncologists see. You know, oncologists are very good. They tell the patient, I want you to come after 2 weeks to get the platelet count down. And the patient is there after 2 weeks, half an hour before the appointment time. So, ladies and gentlemen, all the doctors who treat hypertension, please behave like oncologists. You enforce what is right for the patient and see what happens. With
Thank
those
you, Dr.
remarks,
Ram.
I'll conclude. Thank you very much.
Having spent your lifetime in treating hypertension, you have shared some of the pearls of clinical management of hypertension. We thank you for that. In fact, I have written down some questions to you, but you have answered that already by your last slide about the optimal blood pressure for all ethnic groups. So I thank you, and I request you to take your seat. We will not take any further questions because though we have started on dot, we are delayed.
Oh, you know, it's not no longer a first-line drug as such, first-line combination drugs. You can use any combination that you want. It really doesn't matter because you can add on it. And there is no reason to have first-line drug, a combination of CCB for RAS, or RAS plus a diuretic, or CCB plus RAS. It doesn't matter. Ultimately, patients end up on 3 or 4 medicines. So, which initial combination doesn't matter.
Yeah, we will discuss over lunch if any other pressing questions. I request the next speaker, Dr. Basavaraj Sutar, to come to the podium and give us the lecture. While he is getting ready, I'll just pass 2 statements based on Dr. Ram's lecture. Counseling the patient is most important before you start even the medicines. And even though he emphasized the fact that we should use proper dosages of medication, one should also remember the variable response of various ethnic groups to drugs. That must be also kept in mind before prescribing. Dr. Sutar, please.
Good afternoon, everyone. I'm discussing one case of VT storm. This is the 50-year-old male with hypertension and HOCM on medical therapy since 2010, and he is presented with NYHA class 2 and with recurrent palpitation and pre-syncope. As LV is mild LV dysfunction. At the time of presentation, his blood pressure is around 100/60. As a presentation, this ECG, as he presented with recurrent palpitation and pre-syncope, and ECG showing monomorphic VT. As per my mentor says always, whenever VT comes, you have to localize the VT, proper algorithm. In this ECG showing AVR is positive and V1 is showing RBB. All this ECG suggestive of monomorphic VT arising from LV apex apicolateral anterior region. So, as patient is in VT storm, recurrent VT is going on. We treated with multiple antiarrhythmic drugs, DC shock. With the help of this all antiarrhythmic drugs and DC shock, patient is still in VT. So we plan for further treatment. And we cardioverted multiple times, and patient is again going into VT. And this is one of the ECG after post cardioversion. It's showing diffuse ST elevation. The reason for this ST elevation mostly probably electroporated myocytes have depolarized diastolic potential and altered action potential that can cause the ST elevation like thing, and some other reasons for this ST elevation post shock. So this is the echo of the patient showing obliterated mid-ventricular cavity due to severe hypertrophic and apical aneurysm, and mid-ventricular obstruction with the gradient around 50 mmHg, and that's obstruction around around 50 mmHg. So we did MRI for it's showing hourglass configuration of LV with subendocardial scar in the apical region. So The treatment for this case, we are divided for treatment of mid-cavity gradient, arrhythmias, and thromboembolism prevention. So for gradient, and another one thing, this case in HOCM, around almost 1/4 cases of mid-cavity SCM are associated with aneurysm, apical aneurysm. So we treated with medical therapy for gradient, and one role of pacing also is important for this medical treatment. For arrhythmia, we are planned initially medical therapy, but patient is not reviving with normal sinus, is recurrent in palpitation and VT. So we plan for RF ablation. And we patient as ECG showing north with axis and QS in precaudal leads, and as VT is arising from apical region, and the mechanism of VT here is a re-entry circuit. It may be arising from endocardial, mid-myocardial, or epicardial. So we plan for VT ablation with initially endocardial approach, because RF ablation with VT, recurrent VT or VT storm, it gives around 80% free of recurrence for at least 1 year. So we plan for VT ablation. So depending upon the patient's hemodynamic during RF ablation in VT, we mapped subset mapping, trace mapping, if patient is not tolerating VT. If is tolerating VT, we mapped activation mapping and intermittent mapping, and we ablated VT. These all are findings suggestive of the VT arising from scar located in the LV by angiographically, LV apical region by MRI, and with activation mapping and voltage mapping. And we updated this VT with endocardially and epicardially, and with using voltage criteria. So after VT storm, after ablation, patients plan for ICD as a secondary prevention, and after putting ICD, we measure the gradient after pacing, the significant reduction in the gradient after the apical pacing. So this is a case summary at this HOCM male patient with HOCM with obstructive presentation with mid-cavity with apical aneurysm with recurrent VT, and we treated with medical therapy and along with RF ablation, and we given a patient with ICD as a secondary prevention. So with this case summary, I will hand over the next talk for detailed discussion of VT storm.
Thank you, Dr. Basra. That is a very interesting and complex case. I request Dr. Vignesh to give his talk on VT storm and contemporary management strategies.
Good afternoon, everyone. So my talk will be on VT storm. More correctly, it will be on electrical storm, and this will be a brief overview of how to manage these things. So it could be either a VT or a VF. If there are more than 3 episodes that occurs in a day, or if the patient is already having an ICD, if the patient is having 3 appropriate shocks from the ICD, or he is having an anti-tachycardia pacing from the ICD, then you can label the particular patient is having an electrical storm. So for an electrical storm to occur and to sustain, there should be 3 things. That is substrate, that is the basic disease, and there could be a trigger, and these 2 things will be amplified by the involvement of the autonomic nervous system. As we say, AF begets AF, MR begets MR, VT will beget VT because of the greater involvement of the autonomic nervous system. So first is the substrate. You need to know what you are dealing with. Either it's structurally normal heart or patient is having a structural heart disease. If it is structural heart disease, what type of structural heart is it? Whether this is ischemic or non-ischemic cardiomyopathy or an ARVD or HCM, etc. Why you need to know this? Because the location or the the scar which is giving rise to VT will be situated in different portion of the ventricle. If it is ischemic VT, it could be in the endocardium. If it is from the ARVC, it could very well be in the epicardial surface of the heart. So you need to know which disease the patient in a structural heart disease is suffering. On the other side, if the patient is having completely normal heart, at least by an echocardiogram, the patient can have a monomorphic VT that is predominantly outflow tract VT or papillary muscle related VT, and the other extreme is involvement of cardiac ion channels. That is, it could be congenital long QT syndrome, short QT syndrome, Brugada, and CPVT, etc. Why it is different? It is important to differentiate polymorphic VT or a VF occurring in, for example, in Brugada, and it is occurring in patients with long QT, because the treatment is entirely different. One set of antiarrhythmic is completely contraindicated in one group compared to the other group. To simply put, it's one man's food is another man's poison. So you cannot generalize use of antiarrhythmics in all the subsets in same way. So what are the triggers that one needs to look? Always one has to look at the electrolytes, see for the potassium, see for the magnesium. Always keep the potassium level above 4 or 4.5 in any patient with ventricular tachycardia. Rule out acute ischemia. Also check regarding the antiarrhythmic dose compliance. Or if the patient is having worsening heart failure, please treat the heart failure well. If you feel this is bradycardia induced arrhythmia, please pace the patient. And one needs to know whether the particular patient is having sarcoid, whether it is an inflammatory phase of sarcoid, because apart from antiarrhythmic, if you give immunosuppressant, this patient is more likely to respond. So what is the general, if you receive a patient who is on ICD or without ICD, what are the steps should be followed? Most of the devices are intelligent devices, the ICDs, but still there could be problems with the way the ICD function. It could be like an atrial fibrillation or a supraventricular tachycardia can be labeled as a ventricular tachycardia by the ICD, and the patient may be getting inappropriate shock. There could also be other genuine problem with the ICD in the lead integrity. That is, if the lead is damaged, the ICD lead is going to sense whatever comes across, and it is going to diagnose a VT when in the absence of VT, and the patient is going to get recurrent shocks. So what are you going to do? If you are in an EP setup or in a city, it is easy for you to program the ICD and make these necessary changes. So what will you do if you are in a peripheral center? So first foremost, any patient who is labeled as VT, when you receive, please confirm the diagnosis with the ECG. Rule out all other alternative cause of the wide complex tachycardia. And suppose when the patient is having a ICD and you find it the shocks are due to AF or shocks are inappropriate, then what you can do in those settings is place the magnet and strap the magnet to the place of the ICD generator, so that the therapy, that is shock therapy, will be temporarily disabled. So you can, in meantime, you can figure out what you can do with the patient next. So what will be the general approach if you receive a patient with a monomorphic ventricular tachycardia storm, because that is the most commonly seen VT storm in clinical practice. So first and foremost, it is always you will start an antiarrhythmic therapy. So the three antiarrhythmics, that is beta blocker, amiodarone, and lignocaine, these three forms the cornerstone of treatment of any. You have to use beta blocker in a patient, and if the patient is hemodynamically dependent on inotropes, then it is a different case scenario altogether. So you can use you should use amiodarone and lignocaine, or you can use combination of lignocaine and amiodarone to suppress. An often neglected portion in a VT storm is it's always to suppress the autonomic nervous system. Many times we find patient getting recurrent shock is wide awake without any sedation. An important aspect of VT storm, that if there is a one take home message from this talk, it will be suppression of the autonomic nervous system by use of sedative agents. If the patient is having more number of shocks than anticipated, intubate the patient and put the patient on general anesthesia. And if the patient is further getting VT storm despite these two measures, you do you resort to other measures where you can control the autonomic nervous system, and you can also use hemodynamic support. Using IABP will be a bit of a problem because in a fast heartbeat, if the ECG gated IABPs, it won't function optimally. And finally, catheter ablation. Till you can buy time with all this till you do the patient proper catheter ablation. So first is antiarrhythmic drugs. So in patients with polymorphic VT, as I said earlier, the antiarrhythmic drugs differs. If it is a congenital long QT syndrome, what you do is you use beta blocker, you can use magnesium, verapamil, and pacing, and sympathetic denervation. You come to the Brugada syndrome, where it's totally opposite. What you use is isoprolol or isoprotenolol, quinidine, silastazole. So one group of VF subset is the treatment is entirely different from other subset. So if suppose if a CPVT patient is coming to you, if the patient is having recurrent cardiac arrest, if you're going to resuscitate him with adrenaline, you are going to end up in more trouble. So the first question is, what type of beta blockers we need to use? So most often our tendency is to continue the beta blocker whatever the patient is already receiving. That is, if the patient commonly used beta blockers are metoprolol or bisoprolol, we have a tendency to continue. But what studies have shown is, if the comparative study between propranolol and metoprolol, and also propranolol versus other drugs, the propranolol, the non-specific beta blocker, due to its lipophilic nature, it has shown to perform better in patients with VT storm. And what the second question comes is, what do I do when the patient is hemodynamically unstable? In that, if you want to take a little chance, you can use intravenous esmolol. And the second thing is, there are some old drugs. Old is gold, but we are only aware of the existence of drug from the pharmacology book, which we don't really make good use of it. So this is an algorithm followed in one of the centers in Karnataka. So this is in the patient with acute MI following revascularization. If they find a PVC is triggering a VT or a polymorphic VT. So usually these PVCs originate not from the myocardium but from the Purkinje muscles, because the Purkinje cells are inherently resistant to ischemia because of the presence of huge amount of glycogen, and also they will be able to derive oxygen directly from the cavity. So these Purkinje cells, the PVC can originate from here and they can produce PMVT. So they followed this approach. They used beta blocker, lignocaine, amiodarone, and pacing. When they find recurrence with all these measures, then they used phenytoin or phosphenitoin. This group specifically used phosphenitoin, and the recurrence rate was very less in this subgroup of patients. So ladies and gentlemen, remember, one more drug that you can use in peri-ischemic VT storm is phosphenitoin or phenytoin, a loading dose followed by daily maintenance dose. Other drug that has been studied is quinidine, though it is not available. You can try quinine in same set of patients, that is peri-ischemic patient with PVC triggering VT or VF. So what sedation should we use? Really, there is no hard data. You know, many of the sedative agents are inherently hypotensive as well. So you can, so the commonly studied drugs are midazolam, remifentanil, propofol. You know, cardiodepressant, but propofol has an antiarrhythmic property also. Dexmedetomidine has been studied. So any of these combination of the drug without disturbing the vitals you can use. So I said you have to tackle the autonomic nervous system. One way of tackling the autonomic nervous system where it is easily where we can target is the stellate ganglion. Time is over. Bell was ringing, sir. No. The target of the stellate ganglion block. This can be done in every hospital setup. Get the help of an anesthetist or a pain medicine. If both are not available or expert in this, we can do either ultrasound guided or we can do in the cath lab. So we just find the anatomical landmark, and then we go beneath the common carotid and internal jugular, and it's just a fair localization. You can inject a lignocaine or bupivacaine. This has shown in many studies studies to significantly decrease the burden of the ventricular arrhythmia by decreasing the sympathetic overactivity. The one more way, this is every anesthetist must be well versed, but the problem is many of our patients are also on antiplatelets and heparin. So other thing that you can use is thoracic epidural anesthesia, which most of the people must be well versed. If both are not, you are not able to suppress the arrhythmia, you can also go for surgical thoracoscopic guided approaches to see this ganglion, take away these ganglions. So I said the catheter ablation. What do we do in catheter ablation? Basically, in an ischemic VT or a scar related VT, we just try to localize the area of the scar which is producing the VT, and we ablate in these areas. So this is one of the study where the early institution of catheter ablation in a patient with VT storm had shown to reduce the occurrence of VT, the composite outcomes of death, transplant, etc. So earlier the ablation is better in this group of patient. So this I have already said. In polymorphic VA, every subset the treatment is different. So I'll just finish with one case example. So this is a 17-year-old boy who presented to us fever and recurrent sudden cardiac arrest. So he was sent to us for further management. You can see the patient is having episodes of VF, polymorphic VT. So some of the polymorphic VTs are triggered by PVCs. So what do we do? When we saw the ECG of the patient, so there is nothing in the ECG except for the borderline QT. There were really no clue. But still, you have to put whatever you have learned in practice to subclassify the patient's echo was normal. So this is a structurally normal heart producing this kind of a PVC, and patient is going for cardiac arrest. So what we did in this particular patient was we placed the lead little in the higher position. Usually we place lead V1 and V2 in the fourth intercostal space. Here we placed those leads in second, third and fourth intercostal space. When we did this, we found the classical Brugada pattern. So this was in fact the Brugada patient presenting as VT storm. So the conventional antiarrhythmics are contraindicated, and we were just able to save this patient with isoprenaline infusion, cold saline, because the Brugada, the sodium channels are sensitive to cold saline, and since you know that fever is a trigger, you treat in an opposite way, and after recovery we place this patient on ICD and oral dose of quinine and silastazole. But we ran out of luck after 3 months. So the same patient presented with same type of VT storm at second time also. We did everything possible from our side. Whenever a patient has a VT storm and the patient is on ICD, you should have a tendency to preserve the battery of an ICD. So you should ideally put an external ICD patches in order to save the battery. This patient received as many around 100 shots in a night. So we had to you can see this is an ICD shock. This is during the transit, like every minute the patient was receiving a shock. So we took this patient for an ablation. In Brugada, the classical substrate or abnormality, the sodium channels are commonly abnormal. Those are situated in the right ventricular outflow tract. So we did ablation, so this patient survived after VT. So there are many ways you can treat. So ischemic VT can be treated by ablation. So, but one thing that we should all know in resource poor setting, good antiarrhythmics with a wider knowledge of less commonly used antiarrhythmics, and also the management of autonomic nervous system will be key, and this will go on to help a lot of patients. Thank you one and all.
Thank you very much, sir. That is an excellent talk. I think we should always look for any provocative triggering factors like dyselectrolytemia, electrolyte disturbances, worsening heart failure, and thyrotoxicosis, ongoing ischemia, which are treatable perhaps, which would help in treating the electrical storm also. I request Dr. Narasimhan Garu to give his quick comments.
Does magnesium sulfate have any role in this type of polymorphic VT? Magnesium
in long QT is we can use magnesium, but for any VT for that matter, it's better despite the magnesium level being normal, our tendency is to load because the serum level doesn't reflect the intracellular levels.
Thank you again. I just have again congratulations for a very nice talk. To emphasize one is Inderal is better than the good old propranolol is better than any other novel beta blockers in VT storm, and there is outcome data which supports this. Not only in long QT, even post ischemic VT, good old Inderal gives better outcome compared to the other drugs because of the central membrane stabilizing activity. The second thing is, if you have a chance, procainamide is better than lidocaine. In the absence of procainamide, we rely on a combination of lidocaine and amiodarone. Scar VT, it's I don't know. The results of ablation in fact are better than AFib ablation. If you have a post-infarction scar and a patient has recurrent VT, the success rate is high and the complication rate is quite low. And I would like to emphasize, except among patients where we have taken them in cardiogenic shock, most of the patients will do well. The most difficult substrate is probably hypertrophic cardiomyopathy, and we are just learning about it as we go on.
Any role for LV assist device, sir?
Yeah, for couple of patients with myocarditis, or recently we had a patient with VT storm where you think it's a transient reversible cause. We either go on ECMO or impeller till such time you give again control over VT storm. Post LVAD, we have had VTs from the inflow cannula, where the inflow cannula enters. There can be VT that can be easily tackled by ablation.
VT storm is a nightmare, as you know. But instead of waiting to the next day and repeatedly shocking, could you not have taken him to the cath lab in the night itself for a primary angioplasty last situation?
So the story was this case was dealt when I was a fellow, and that was on a Saturday night. So all our consultants have gone for an All India National EP conference. So I was the night watchman who was taking care of the patient.
But you did well. Thank you.
Yes.
You saved the patient. Okay.
I think with this we conclude this session. I and Dr. Mirajra, we thank Dr. Narasimhan Garu for this excellent opportunity to participate in this uniquely structured education program. Thank you, sir. Thank you very much.
And Vasant, anything to say? Last
Yeah,
word?
Vasant?
No. Okay.
He is not
Bye.
there.
Thank you very much.
And thank you, sir. So just our last session. So I'd like to invite Dr. Krishna Mohan, Dr. Daljit, and Dr. Kumar Narayanan to join us on stage. We have 3 challenging cases that will be shown.
So good afternoon, one and all. This is the last session of the day. After that, we have cardiology quiz. I suppose Dr. Abhijit is not there for his presentation. So we'll start with Dr. Arun Gopi. He'll be showing a challenging clinical problem solved by an ablation.
A warm good afternoon to all. At the outset, salutations to my teacher Narasimhan sir, Krishna sir, and my colleagues Daljit and Dr. Kumar. It's an honor and privilege to have an invitation from my teacher and mentor Narasimhan sir. And in the next 10 minutes or so, I'll be just alluding to not a complex procedure as such, but a very tough clinical situation, which is actually quite draining on the patient as well as the caretaking physician. This is a problem which brings the patient repeatedly to hospital, gives nightmares to the treating physician, has repeated hospitalization, drains a lot on the finances. But finally, with all the advances that scientists have given us in the current electrophysiologic therapeutic armamentarium, we have now hardwares which give us the ability to treat these complex diseases, which probably a one-shot solution. So the story cut short, it's a story of LA flutters being managed with multi-electrode catheter based mapping and ablation. So okay. So I just placed 3 clinical scenarios, but probably most of them denote the same. Just allude to the first one over time, and the next two are almost similar, just showing different the intrinsic changes which are different in the same clinical picture. First case is a rheumatic heart disease patient, 62-year-old, post MVR for severe mitral regurgitation with a tilting disc valve, underwent a modified Cox-Maze procedure in a different center. Was done way back in 2005. We didn't have the surgical details of what was done during the Cox-Maze procedure. But unfortunately, off late, she has recurrent hospitalization with heart failure, every time precipitated by an incessant tachycardia. Cardioverted at multiple centers, drained out the patient totally, multiple cardioversions, tried on every drug that we had, amiodarone, metoprolol, digoxin, some gave flecainide, polypharmacy tried, everything tried, but despite that, recurrent hospitalization with tachycardia, precipitating heart failure, and no response to medical therapy, and came to us for anything beyond medical therapy. And this is the ECG of the patient when patient was brought to the lab. So see, this is typically a regular narrow-QRS tachycardia for the practicing physicians. This is a regular narrow-QRS tachycardia at a rate of almost 150 with something midway between the two QRS, which is the P wave. This should be a spotter for a graduate that this is probably a flutter, but unfortunately, this was labeled as sinus tachycardia at multiple centers, precipitated by heart failure, and was treated as sinus tachycardia. Just to point out that whenever you have a patient in decompensation, and if you have this kind of ECG incessantly running around, a regular narrow-QRS tachycardia with a P wave in between, it's typically a flutter. So this, we put in a coronary sinus catheter to see what is the activation pattern. Typically, CS showed a near simultaneous activation of all the electrodes, ruling out the classical RA flutter, which is the most common flutter we see in our clinical practice. The hardware is essentially the same for all these kinds of LA flutters. We go under general anesthesia, use paralytics, a radial puncture for the hemodynamic monitoring, because generally these procedures tend to be long, a right internal jugular axis or a left femoral axis for decapola for the coronary sinus, which is our both anatomical and electrical reference, a right femoral 8 French axis for mapping and ablation, multi-electrode catheter. We generally are a good fan of HT grid catheter from Abbott for activation mapping, 10 French sheath from the left side for eyes, which ensures more safety in these procedures, and then the ablation finally delivered with a flexibility DF curve catheter. So a point about the technological advancement which has really made us map and ablate these kind of arrhythmia. This is from Abbott, and there are other catheters from Biosense Webster as well. This is Advisor HD grid mapping catheter, which is actually a 16 electrode catheter. You can actually see it's a 4x4 grid, 2.5 French on each side, 1 millimeter electrodes at 3 millimeter distance, each about 4 grids, total 16 electrodes, gives you tremendous ability to map multiple points at a time. The most important aspect of this is it takes off the concept of bipolar blindness. So for a bipolar mapping catheter, which was the way Narasimhan sir would have done it earlier, would have taken many hours together, any wavefront perpendicular to this would not elicit any electrogram on your bipolar mapping catheter. But on the grid, you have mapping in both directions. It ensures essential good tissue contact and essential excellent mapping resolution, takes away the bipolar blindness and gives you good information on what is going wrong. So this was a tachycardia running at a 300 millisecond cycle length. Window was -200 to 70. The anatomical reference was CS7. And most of these, we start off with the right atrium. right atrium typically would not cover any of the circuit, indicating that right atrium is just a bystander of the circuit, and less than 50% was covered, and earliest of the activation were in the septum. So typically we take the access to the left side of the heart. Transeptal is always now currently with intracardiac echo guidance. As earlier showed, it reduces the fluoroscopic exposure, no need of an aortic pigtail. Transeptal is done after full heparinization that ensures or reduces the risk of stroke. We don't have any aortic pigtail reference catheter. Traditionally, what would have been done for a balloon mitral valvotomy. And puncture is not with manual pressure with an SLO BRK needle. It's an electrocautery 40-watt cut. One shot, it gets across into the left atrium. And in this case, the challenging scenario is the tilting disc valve, which is there. We have to ensure that we don't go near the valve. So we don't take the protract wire, which is the jalebi wire, which should have typically placed in the left atrium. So we take a wire into the left pulmonary vein and then track the agilis over this, which is our sheet for mapping and ablation. And essentially, we map with the ablation catheter around the valve to ensure that we don't go across the valve because it's a tilting disc valve. But with the ablation catheter, you realize that you are not covered any part of the circuit. With ablation catheter, the problem is you don't have much contact. Less than 10% of tachycycle length was covered, and then we take up the grid. Grid ensures excellent contact. You can see the excellent contact in the roof. You're able to map entire circuit. You're able to push safe. It's a very safe catheter. You can push towards the LA wall. You can see how it hugs on the LA roof, ensures good contact, and you are able to map most of the circuit with intracardiac echo and fluoro guidance. You stay away from the valve. You need to have fluoro throughout the procedure to ensure that you are away from the valve. And once you have mapped this with the HT grid, you keep the ACT throughout the procedure between 350 to 400. And this is the activation map. For most of our EP colleagues would understand what is happening. It's an activation map. The scar definition was 0.1 volt, less than 0.1 volt being defined as scar. And we find a lot of lines of functional block in this patient Cox maze. We find a lot of functional block. Now, once we have got this map, we just co-register with the traditional maze procedure which would have been done. So this is the traditional maze procedure, and then our line of blocks more or less correspond to the lines what the surgeon would have given. The pulmonary veins were totally silent. You have this mitral isthmus line here, you have the posterior pulmonary vein line here. What essentially was actually missing out on this is actually the roof. Actually, you find actually a gap in the roof, and then when you run through the activation mapping, this is the color code. It goes from white to purple. This is from white, red, orange, yellow, green, purple. It goes around. So when you run the propagation, you understand where the circuit is. It's actually this is how the flutter circuits maintain itself well. It's a macro-oriented circuit in the left atrium. That is why these tachycardias tend to be incessant, just not responding to any form of medical therapy. They need cardioversion, and if you run these circuits, you realize it's actually a roof-dependent circuit. The pulmonary veins are silent. It's actually a roof-dependent circuit running between the gap that the surgeon left around the roof. And once you have all this information from the grid, then the next part of the job is quite simple. You have deciphered a complex circuit into a simple. We know what to do next. We just have to take in this is the agilis sheath, the flexibility catheter, take into the roof at 35 watts, 43 degrees, 17 ml per minute irrigation. You just start drawing a line connecting these two. This is a plan of line which the surgeon had left around, connecting the two pulmonary veins on the roof, a target roof line, and we tried to target this line and with point by point ablation. And after almost about 2 hours of mapping and understanding where the circuit is, it just takes about 15 minutes of ablation, connecting the two pulmonary veins. And as we ablate, the tachycycle length prolongs and it terminates. So all of this is possible because of this catheter, because you take this catheter, if there is not good contact, this is what you see. With excellent contact, you see this is how the signals which are predicted. So these signals are the one which are game changer in these kind of scenarios, and these multi-electrode catheters actually enable us to map these catheters, understand where the signal is. And once you have ablated this, it's not enough to just ablate and come out. You need to ensure that your lines are not pro-arrhythmic. So post RFA, we ensure that there is a line of block across this line. So we map across this line. You find that there is a 140 millisecond time gap between the line. So there's a transisthmus line, a time of almost 143 milliseconds, and the posterior wall actually shows inferior to superior activation. So this is the voltage map after the ablation, which indicates that all the veins are silent, and one line connecting that whole line is gray. That means there is no voltage there. So this is a patient which had incessant arrhythmia, mapped with one ablation, and finally with about 10 minutes of ablation, we had a permanent solution for a vexing problem. Just two more cases. The rest two cases would be very short. Similar scenario here. It was a post CMV patient, recurrent atrial flutters, mitral valve, no hemodynamic obstruction, again incessant tachycardia. This was a tachycardia in the lab. These LA flutters are just incessant. Whatever therapy you give, they will come back, and CS activation almost simultaneous. Mapping essentially, hardware is essentially the same. RA covers nothing. We go to the left atrium. You can see how large the left atrium is. You can see this is the Agilis catheter, and the whole of HD grid, this whole LA was almost aneurysmal. Such a huge left atrium. But the HD grid catheter ensures excellent contact, and it covers most of the circuit actually. And once you see the signals from the circuit, actually you can see actually there are actually two scars in this scenario post CMV. So they had approached the left atrium from two punctures, the puncture near the right superior pulmonary vein, and there's a scar near the mitral isthmus. So this is two scars on the posterior wall with a voltage definition of 0.1, and these scars to define. We actually find really fragmented potentials between these two scars, which cover almost 290 milliseconds of the 360 milliseconds of the cycle length. So the entire circuit is covered here. That means this is a slow conducting zone between the two scars, which is maintaining this circuit, and that is why these tachycardias are incessant. These scars are actually again defined by split potentials with almost an isoelectric line between them, and this is the propagation. You can see how it propagates. It is between these two scars. The circuit propagates, goes around, comes around, and this circuit maintains the arrhythmia. And with grid, actually, and actually understand, it's actually a figure of 8 circuit. This is a figure of 8 circuit in the left atrium maintained by a common isthmus. There is a common isthmus between the two dual loops, and what you have to just do is find this isthmus and just ablate. All of this is possible because of this catheter. You see what signals are shown by this catheter at that site. You can see really fragmented signal covering 290 milliseconds of the 360 milliseconds. But with the ablation catheter there, you can see it would almost be silent. The ablation catheter does not have contact there. It's a 2-5-2 spacing. There's a 2 mm electrode which looks at only one direction. You will miss a lot of electrical information. But with the grid 1 mm electrode, 3-3-3 spacing, it records in 2 orthogonal planes. You can get the entire circuit there. And once you have found this, just a point ablation.
Dr. Arun, we are just running short of time, so you can just continue.
Just a point ablation, and the whole tachy terminates with one single ablation. So one ablation here, the tachy terminates, and an incessant tachycardia is just terminated. So this is essentially the same scenario with the third case also. So I'll just conclude. These were cases where the patients present with incessant tachycardias. Most of them are because of macro re-entry in the left atrium, typically left behind by critical gaps in the lines. Early in the first case, because the line was left behind the surgeon in a Cox maze, led to incessant tachycardia. High density mapping using HD grid catheter, which is a multi-electrode catheter, defines these loops and the critical isthmus. HD grid actually picks up signals which actually missed by point mapping using the ablation catheter. And the first case with a roof line, after confirming bidirectional block, we had complete cessation. We had cessation of tachycardia and no recurrence on follow-up. The second case was a post-surgical LA, which was huge, but it was not huge because of scar, but it was huge because of atrial myopathy, because of incessant arrhythmia. HD grid catheter, in addition, ensured excellent contact, gave us a lot of signals, understood what is going wrong, and identifying the critical isthmus. And once you have identified the critical isthmus, just a point ablation. Tachycardia is running incessant for years. Just 10 minutes of ablation at that critical isthmus, we have permanent termination of tachycardia and no clinical recurrence on follow-up. So just the point to highlight is, although these are complex clinical problems, with the current advent of newer mapping catheters and scientific advancements, we are able to map these incessant tachycardias. And once you have mapped, ablation is just a straightforward 5 or 10 minutes job. And once they are ablated, this is actually quite rewarding in the sense these patients are clinically cured of the arrhythmia, and they have a good quality of life after the ablation. Thank you.
Thank you, Dr. Arun. I think due to shortage of time, we'll go on to the next cases and then we'll take the questions later. Dr. Devabrata Bera will now present his challenging device case.
Good afternoon, everyone. By the time my presentation is uploaded, many thanks to Narasimhan sir, and it's a pleasure to come back to Hyderabad, which has given me a lot of sweet memories, which has given me the best mentor Narasimhan sir one can ever expect, and very nice friends like Dr. Daljit and Sachin sir. So coming to my cases, respected chairpersons, please stop me when my time is over, because Muthaiya has strictly given me 10 minutes. So it'll be very simple, 1 or 2 cases, and I'll go slow if there are beginners or youngsters who are starting devices to do. So a couple of device troubleshooting cases is a 75-year-old gentleman who had a complete heart block and had a pacemaker. It's a single chamber VVI pacemaker It was implanted almost 10 years back, and he was doing well otherwise. And recently, of late, there are episodes of recent recurrent dizziness. So this was the ECG. It's a old ECG in the file, which was a lower rate limit of 60. As you see, he is completely dependent with a rate of around 60. And this is the present ECG. If although looks like everything is normal, but you have to be careful that, as I said, his lower rate limit is 60, unless you have a hysteresis on, unless you have the hysteresis on this interval, which looks like a little longer. And if you track back from this pacing spike, if you go at 60 rates per minute, then the previous QRS would have been here. So it is, if in EP it's very easy to pick up, but for young cardiologist, I'm just trying to say that this gap is little long. You expect the previous QRS somewhere here. So the lead may have, or maybe picking up something or oversensing something. That is one of the subtle clues. With magnet, you see everything is all right. That also tells that maybe the patient is having some kind of oversensing. If the patient is having recurrent dizziness, was otherwise doing well, excluding the other causes of dizziness and syncope, the neurological causes. Once you do the Holter, you can find something like this. In this patient, we were fortunate enough to pick up. There was complete loss of pacing spike as well as QRS complex. So as previously shown by Kumar Narayanan sir, that when you have pacing spike but no QRS, we call it loss of capture. And when you do not have any pacing spike at all, then it is called loss of output. And the most common reason that the device is seeing something else and is not giving its impulse. And the commonest cause of oversensing in clinical practice in especially older devices are oversensing. Fortunate patients like here, we will find that there are some lead noises like here. As you see, these are the small minuscule artifacts which are most likely or most commonly lead noises. And what happens when there is a lot of lead noise? This was brought out by moving his arms, that the patient was having this kind of lead noise which is being picked up as V-sense in the Merker channel. So for the device, this is something like a non-sustained VT. But in a dependent patient, you do not have any ventricular pacing event, and the patient can have a transient asystole. So this patient had an increase in the lead impedance, which is suggestive of a lead fracture. And another subtle clue where that this patient is having some abnormality. Even if actually what happens, many patients cannot may have no change in the impedance or no change in the threshold. But what will have a dependent patient till now who was having completely 100% V pacing, suddenly you see the V pacing has dropped to 68%. This tells you that the patient is saying something else as the ventricular sensed event. So this patient showed that there is some abnormality in the lead, as you see here. But in many patients, there will be microfracture or micro insulation break, which is not visible in the X-ray, which will be not visible in the fluoroscopy, and just oversensing with the kind of lead note which I have shown like this is enough to change your lead. There may not be any change in the lead impedance. There may not be change in any of the threshold. So this patient underwent a lead revision. So just maybe one case in next 5 minutes to discuss about ICDs, to give you a test of ICD, although you may not be frequently seeing them. So what happens in ICD before you go into troubleshooting, you need to understand this basic principle. So in the lead, there is in the tip, there is tip to ring, the sensing happens here. Means for the device, the eye is here, the sensing happens here. Although the discrimination means the morphology or the template matching, whether the QRS morphology is similar to his sinus, happens from the far field, which is like can to coil. So this is can or the pulse generator to the coil. So this is the comparison or the template match happens from here. Otherwise, the sensing happens generally from the tip to ring, which is called near field, and this is the comparison or the discrimination is called far field. These two are the ventricular channels, and one basic rule of thumb, they will go hand in hand. That means if a patient has a VT, both the near field and far field should show VT. It cannot happen that one channel is showing VT, the near field, and the far field is showing sinus rhythm. This discordance means there is something unusual, there is something abnormal. So I'll just show one or two cases like this case, who was a ischemic cardiomyopathy patient with a history of VT and ICD in place. You see this is the atrial channel, this is the ventricular channel, which is called near field, and this is far field, which looks like a QRS, where the near field looks like a spike. So there is A sense, V sense, A sense, V sense, and importantly, the near field and far field go hand in hand. They are together, simultaneous and similar. When there is an onset of tachycardia, you see V is more than A. The number of QRS complex is number or more than number of P. So this, with the rule of thumb, V more than E is suggestive of VT. And importantly, the V in both near field and far field go together simultaneously. So this is a true ventricular tachycardia, where you have V more than A and you have each near field and far field together. So this patient had appropriate therapies for this VT. So he developed in fact ventricular fibrillation. You also need to see how the ventricular fibrillation look like. So it's like a ECG, what you see in a 12 channel or single channel ECG. It's a genuine ventricular fibrillation in contrast to artifact, which I'll show you in the next slide. So this patient receives a shock and there he comes back to sinus rhythm. So this we will call is a appropriate therapy. So for him or her, you have to give drugs. You can consider ablation or sympathetic denervation. Sometimes in VT storm as depicted by Vikram, you need to give sedation and sympathetic denervation. In contrast, this is another case where you can see that this is a single chamber device and he came with a possible alarm and episode. So what you see, this is the near field, sorry for the quality of the picture, and this is far field, which is called discrimination. You see the near field shows so many spikes which has been reflected in the marker channel, but the far field has a lesser number of QRS complex. So there is a discordance between the near field and far field. This tells you this will be definitely either a lead noise or it can be a EMI. EMI is generally noted in all channels like atrium, ventricle, near field, far field, but this can happen. So this is definitely not a VT. Had it been VT, both the near field and far field would have got this similar very fast noise-like phenomena. So which I have shown in the previous case. So this patient actually had a lead noise and he needs a lead revision. Shall I stop here or I'll go to the next case?
We'll stop there.
Okay, thank you so much.
Thank you.
Now we invite Dr. Sachin Yalagudri, a bright electrophysiologist working at the home institution. He's going to talk about challenging ablation in adult with congenital heart disease.
Very good afternoon, all of you. Thanks for the opportunity here. So I will not take much time with the hunger pangs being there for all of you. So this is one of the arrhythmias which we ablated in the grown-up congenital heart disease. So this is, to summarize this slide, is a 40 years male who had a single ventricular physiology. He has undergone a Fontan surgery in 1989 at the age of 7 years. He had a recurrent palpitations and he had been in a NYHA class 3 for more than a year. And there had been attempt of ablation in other centers, and then he was not responding to all the possible antiarrhythmic drugs and cardioversions. So what is the next choice for him? Either we have to go for a catheter ablation or he has to go for a transplant. That's the status of these congenital heart surgeries. This is a flutter ECG. I don't want to describe more on this. Even description won't give where it's arising from in any of the chambers. So the whole challenge for us was the anatomy in this patient, because there is no surgical notes were missing. We tried to trace them. There is no surgical note. So we need to understand in congenital heart diseases, first of all, what is the anatomy that looks like in these patients. So we did in cardiac imaging, that's a CT scan, which was 3D constructed. Sorry, 1 second. Running. Okay. So there is this is the, you can see this chamber here. Let it come back. So this is luckily a classical Fontan where the this IVC drains to the right atrium, and then this the appendage is connected to the pulmonary arteries, bypassing the right ventricle there, and we have SVC comes to the same chamber. This is one of those classical fountain which was described initially by the fountain. He himself stopped doing it in the future, and there is a patch here which closes the connection to the left out tiny atrium and then the ventricle there. So this anatomy is very important because which chamber we have to enter, and then planning is very, very important. So this is an aorta here, and then you have got a right ventricle, and then this is the left ventricle here, and then the fountain circuit. So why we need to understand all this anatomy is that for the approach. So you can have a flutter circuit entirely in this chamber, will be very happy if that happens. But if it is part of the circuit is on the other side where we have to puncture the baffle, there's no baffle actually, the patch, pericardial patch, we have to cross and go because it's not a regular interatrial septal puncture. So we need to plan it to approach this. We can approach it in a two ways, either by doing a baffle puncture or retrograde enter the aorta and reach this. So either way it will be a complex one. So we planned for this one, and then he needed a anticoagulation. And then one more challenge is to get a stable atrial reference, as Dr. Arun was showing you. You need a electrogram to have a reference there. And then this is our regular tricuspid isthmus. It is nothing but the area between the tricuspid annulus and to the IVC. This is a simple one here. But if you go back and see here, the part of the isthmus remains in the other side. So this is a typical flutter which is common in these patients also. So we need planned in that way. Then this is the part of the tricuspid isthmus what we are showing remains on the other side here. And to approach this, either we do the papal puncture or go retrogradely. So as Dr. Arun was showing, there was a lot of catheters you can see in the heart. We cannot place it here because the coronary sinus was there. We cannot reach the coronary sinus in this case. We have to put one permanent atrial lead and use this for a mapping reference. So look at the chamber, so huge. Wherever you try to place, there is no contact, and then screwing this took its own time. So then the rest of the thing was much more easier. So this is the atrial reference what we had. I'm not going to spend too much of time on these things. So we mapped, as Arun was showing, this is something called as a CARTO system where we mapped with a multipolar catheter here also. So we got this is a activation map on something called a coherence map in the CARTO system, which shows how the propagation of impulses happens, and it shows something called as slow conduction zones. It's like a bottleneck in a traffic. So you catch that bottleneck, you can stop whole traffic. So the similar way, when the flutter is running, we need to stop it at somewhere. So the two areas of a slow conduction, this is the one, and the other one is here. This can be multiple in the same heart, but we have to find out which is the cause for this this flutter circuit. So this was the cause for this flutter circuit, which we identify something called as an entrainment mapping. So here was the slow conduction zone, and we did it by doing an entrainment mapping. So there is here when you go superiorly, there's a connection from appendage to the pulmonary arteries. Below there is a lot of scar. So this remained for us an zone for blocking this. It's like blocking a narrow area in the circuit. So this is what we're talking about, entrainment. So there was a entrainment showed fairly good PPI TCL here for EPs, and here it was 0. So here one lesion terminated the tachycardia. Further we had that line of conduction block we created between these two areas to make sure flutter doesn't happen. So patient remained in sinus rhythm. At 4 months of follow-up, he remains in class 1 to 2. He is doing well. So atrial arrhythmias in ventricular heart can worsen the cardiac hemodynamics and worsen the heart failure. They go very bad. They will have all those right heart failure symptoms, and then the only thing we can do is either if we can give a good palliation with ablation, or they are a candidate for transplant. Can be challenging. Preoperative imaging can assist in planning and the approach. Not all these arrhythmias are CTA dependent. So we are lucky in this that we need not have to do the baffle puncture, but we are very well ready, prepared for that. And it's all the team approach. We planned it for almost a week's time. Narasimhan sir, Preetham and the imaging team were all there. I was there only for the ablation. Rest of the things were done by our team. Thank you so much. Any questions for all the panelists? We are ready to, happy to answer it.
Excellent case. I hope you have published this one, yeah? Very unusual. Any questions from the audience to start with? Questions for both Dr. Arun and Dr. Sachin. And of course, Dr. Bera as well.
So if there are no questions, Arun is there. Arun, they were really very, very good cases. My only question to you is how long is the follow-up of these patients?
So there were essentially 3 cases. The first one was done about 2 years back. So we have a 2-year follow-up. She is in sinus after that throughout the time. The last 2 were in the last 1 year. So we have 6 months and 9 months of follow-up. So they both, all 3 are doing essentially good.
Thank you. Yeah. Dev, I think you didn't show that it was good. It was unipolar pacing. And to buy the time, I think you kept it in a VOR mode. That is a teaching point for the people. Till you are doing the revision for the thing, you have kept it as a non, so that it doesn't sense at all. And your patient was completely dependent and you kept it in a VOR mode and unipolar pacing so that there is no loss of capture. So if there are no more questions, we'll close this session. Thank you very much.
So I'll ask Narasimhan sir to have final comments on the meeting, and then we'll come to the end of meeting. After we close the session after vote of thanks, we have a quiz to be conducted in the same hall. There will be a lunch. So the students will stay back in the hall and then complete the quiz and have a lunch, and rest of them will move for the lunch. Sir.
Good afternoon, everybody. It's actually a very gratifying meeting because the purpose of the meeting is to have a shared learning, and the shared learning happens only through interactions. The problems that we face have to be discussed together, and that's what was the aim of the meeting, because no amount of guidelines can substitute real life cases and the problems that we have seen. And I would like to congratulate my team, Muttaya and Sachin and Daljit, along with Malav and Tahir, who sat together and conceived and put together this meeting. In addition, we had tremendous support from Rajiv, Anuj, Prasad Reddy and the rest of the team to make this possible. And last but not the least, any amount of meeting, the success of the meeting essentially depends on the faculty that we have. And we have tremendous faculty, the speakers and the chairpersons who guided us through the program. Sorry, we were little late, overstepped on time, but nevertheless it went on quite on time. And this kind of a meeting is not possible without a financial support. And we are immensely grateful for the tremendous support. Number one, we had from the administration, Dr. Nagesh Reddy and the administrative team who had worked behind the scenes. The AV team headed by Satya, Robin and Mohan and others who had been working back and forth again to make this possible. And the financial support for this was made possible by unrestricted grant from Pfizer, USV, Sun Pharma, Medtronic, Abbott, and JB Chemicals and Tasmet Chemicals and Boston Scientific. And we are also grateful to have very active and engaged students who participated in the quiz, which made this possible. And most importantly, it's kind of a homecoming for several of us, and shaking hands with our old friends. And this was made possible, and this is more an opportunistic meeting when we could meet up with all our old DNB colleagues who had been trained in care, and our faculty who are colleagues for many years, and then all our EP fellows who actively participated in this meeting. I would like to thank, if I had forgotten anyone, it's purely by oversight. Thank you very much, and let's break for lunch and we'll have the quiz simultaneously arranged. And before, I again would like to emphasize, majority of the work was done by Muthaiya, Sachin and together. And only request for Muthaiya is please don't take so much on yourself. Please share your responsibility with the rest of it. We are worried that he'll going to have a burnout. That thing. Right from arranging the cab to arranging the travel, he was running around doing everything. I think you should, this is a phenomenal meeting, and thank you all to everyone. Thank you.
Can you just have a count of the number of teams who are there? Can you please write down? Can you please come forward? Just need to know the count so that whether we need to conduct any prelims or we'll directly go with the finals. So I think exactly 4 teams are there. Please come forward. First row. All the participants are requested to come to the first row, please. Three. 1, 2, 3, 4, 4. You want to participate? Huh? Participating, please come to the first row. You know, I'll have a count. It's a team. Right. Do we have the 5th buzzer? I think if there's a 5th buzzer, we'll directly go with the finals or 4 only available. No, otherwise I will run a prelims. Run the prelims. Can you please? So for want of time, the prelims, we will conduct the prelims in just 10 questions we'll do in the prelims. We'll keep it at 10 questions. Just AV person. Yeah. 1, 2, 3, 4, 5 teams. 5 teams. Only 5 teams, no, participate. We'll go directly with the final quiz. We'll have 5 teams instead of the 4 teams. So there are totally 5 teams. I request you to come forward and sit in the chairs. We will check the buzzers first. You will be team A. You'll be team A, your team B, team C, team D, and team E. So now, just please introduce yourselves first. Please take a mic. You can sit down and introduce yourself.
My name is Vinod, sir. I'm from Karnool Medical College, final year PG, sir.
My name is Sivakrishna, sir. I am from Karnool Medical College, final year PG.
Now, can you check your buzzer once? Yeah, fine. Team B.
This is Balchandra, sir, from Usmania.
Balchandra.
I am Ganesh, sir, from Usmania Medical College, final year.
Thank you.
Sir, I am Dr. Nandan from Star Hospital, second year. I am Dr. Sajjad from NIMS Hospital, final year.
Yes.
I am Dr. Naveen from Usmania Medical College, final year.
Dr. Varaprasad from Usmania Medical College, final year.
Dr. Bhargavi from PSIMS, first year.
Myself, Dr. Pavan from Dr. Pinnamaneni
Can
Siddhartha.
you be a bit loud?
First year PG from Pinnamaneni Siddhartha, sir. Dr. Pavan.
So, the quiz competition is going to be completely a buzzer round where we'll have a set of 16 questions. The the toughness of the question will be depending on the mark. So when you take a 50 by choice, if you're taking a 50 and if it is correct, you get 50 points, and if it is wrong, you get minus 50. Okay, so we'll start first question. Minus 150. Who? Get it wrong, it's minus half. Minus 75. Right? Okay, so first question alone I'll display first. Diagnosis. I'll give a clue. Okay, okay. Yeah.
Six sinus syndrome.
Six sinus syndrome. Okay, I'll give you a clue so that this a procedure was done during this Holter. There's a young male who presented with syncope. We did a procedure during the Holter, and this was recorded in the Holter. Okay. No negatives, but I would anyone like to try? Okay, team C. Yeah. No, it's yeah. So, okay, so this is it was recorded during a HUT. It was a cardio inhibitory syncope, which it recorded. Because since it is not very clear, we will not give negatives for this. But I would request team E to choose one of the questions. Yeah, so this is a cardio inhibitory syncope where post NTG, patient was in standing position in NTG. Patient develops a complete arrest of the sinus rhythm, and there is complete asystole, which was preceded by vasodepressor response. This is a classical cardio inhibitory syncope, and this patient benefited from a pacemaker later. There are some specific types of pacemaker also for these conditions. I think that this will be good for your future reading. So, team E, you can choose the question. You need an answer, just choose the question.
Hundred cat.
100 in the second, third, which row?
Cat.
100 cat. Okay. So please be ready on your buzzers. This patient post CABG had a previous myocardial infarction. Team B.
The LV angiography.
LV?
Angiography.
LV angiography, yes. What is the diagnosis?
Apical ballooning.
Apical ballooning. I have to give negative for that. Would any other team like to try? Team C? Pseudoaneurysm. But since it's a past question, I will not be able to get any marks. This is a pseudoaneurysm, and since this was a post-surgical candidate, we had done an endovascular closure of this with the ASC device. Want to go half? Okay, we'll go half. Our second quiz master fields. Okay, so team D, as a team B, you can choose the next question.
Echocardiogram. 100 echo.
100 echo. So buzzers. And this it may play. Yeah. Again, team B.
The echocardiogram apical four chamber view showing dilated RA and RV with a mass in the RVs. Cardiac tumor.
The question was the differential diagnosis.
Cardiac tumor.
Cardiac tumor. What tumor would you think of in a patient, a 2-year-old?
Rhabdomyoma.
Rhabdomyoma.
Of the differentials.
What is the typical morphology of a rhabdomyoma? Rhabdomyoma is usually small, myocardial mass, multiple mass in association with tuberculosis. So this is more of an endocardial mass.
Thrombus can be differentiated.
Thrombus, yeah, but thrombus, such a large thrombus, we don't expect the patient to survive. So yeah, one of the differentials we'll still consider thrombus anyway. Okay.
Endocardial fibroelastoma.
Fibroelastoma, no. Anyone would like to give differential? This is more of for learning than for actual quizzing, so be happy to interact. Huh? Huh? Play. No, absolutely no. So this is an obliterated RV cavity, especially if a young patient coming from, especially from Kerala, still you would like to take? Kerala coastal area, endomyocardial fibrosis. So other differences, yes, cardiac tumor, not rhabdomyoma. Cardiac fibroma is more likely presentation. Of course, lymphoma and others can also, malignant metastatic tumors also can present in the similar manner. This patient, we were fortunate to do a MRI and confirm it was endomyocardial fibrosis. Okay, team B again. You can, yeah. No, team B chose the question. You chose the? Yeah, okay. Okay. Anyways, answer doesn't depend on. Echo on 150 echo. 50. Post MI. It's kind of the easiest echoes. Yeah, team E.
Post MI ventricular septal.
Buzzer, fine. Huh? No, it's not direct on you. Who was hitting the buzzer gets it. Huh? For every question, we are following the same thing. So that's it. Team E.
Post MI ventricular septal defect. Post myocardial infarction ventricular septal defect.
Yeah,
Rupture.
that's correct. 50 questions. So you can choose the next question.
50 electrocardiogram. 50 electrocardiogram.
That's over already. That was the first question. There's one more 50 electrocardiogram. Yeah. It's not an electrocardiogram. This is a cath. Would you proceed? Okay. This is post PTCA stent placed in 2014. I would like you to identify the stent placed from left main to LAD. There's a peculiar quality of the stent, so to identify it, that's why. Yeah, team D. Can you please give the mic? It's a bare metal stent. That's what you're told, no? No, it's not a bare metal stent. You get negative for that. Anyone else want to take and pass? 50% of the mark total. Special prices. Dajit man, if you should try. Yeah, team.
Covered stent.
No. Again, should we give negative for the pass? It's open to the audience. Anyone who would like to try in the audience? No. Biovascular scaffold. The typical two dots which you can see is the typical two dots. This is peculiar about the biovascular reabsorbable adsorb stent. This is not used nowadays. Device 50. This is a series of, this is the ECG of this patient. Okay. Can you say what is happening in the ECG? This is just part one of the question. And once you get the part one right, I'll show the X-ray also. Now anyone can take on the buzzer. Yeah. Yeah, it's a dual chamber device. Yeah, loss of capture. Yeah. So team C, this is the part one of the question. What is the diagnosis? No, team C will be answering the part two. Lead fracture. Second, there's a specific syndrome. It's okay. We'll accept it. It's subclavian crush syndrome. Yes. So that's why it is essential to take the axillary vein puncture or a extra thoracic subclavian puncture to avoid this complication. And this particular patient was initially managed with a unipolar pacing. So the tip to the device was pacing, and then later the patient had the lead replaced. Okay, now all the 50 marks questions are over, so don't choose any 50. Team C again, you can choose your question. Undercut. No, yeah, undercut is over. It doesn't really matter. You are not going to answer. Okay, 150K? Yeah. I need you to explain what is the angiogram, which view we are taking, and what is the diagnosis. Please hit your buzzer and then answer. Yeah, see. Aortic root. Okay. What is the chamber which is getting filled? Please get. Huh? So what is the diagnosis? Yeah, RSOV of yeah RSOV of RCC into RV. Additionally, if you can describe what is the what do you call it? What do you call this specific filling pattern? Okay, it's okay. It's a windsock deformity, and it's a rupture of sinus valve of RCC2. So they get full marks. 150. Again, team C, you can choose the question. Yeah. Anything is okay.
Coronary complication.
100. They got used to this complication, I guess.
Catheter entrapment because of sting, sir. We can use with the stiff guide where make it straight and.
No, please speak in the mic. Stiff guide wire one.
O35 guide wire to make the loop unlooping, and we can remove it.
Okay.
As we are removing it back, the lumen of the artery will be getting slower. We can push it back to the higher lumen, and we can enter.
Excellent.
Unloop it.
Is there any other thing you would suggest? Any other methods you would suggest to remove the kink? It's okay. You get full mark. So it is essential when you identify a kink to push it to a larger vessel where you can untwist the catheter and push a stiffer guide wire to straighten the catheter. If that is not possible, you can always tie a BP cuff which provides like a pivot to untwist the catheter. And the other method is to stare the opposite side and untwist it. So this is what was done in this particular case. So the distal end was captured with a snare, and then the distal end was captured, and the catheter was untwisted, and the guide wire could be passed, and the catheter could be removed. And it could have been essentially avoided by just noting the hemodynamics. Yeah. And there's one more. Team D. DD. Yeah.
Sir, 150 cath is present.
150 cath is over. Okay. Team D.
Sir, it's an RCA angiogram showing coronary distal coronary artery rupture is present, and is the filling of the into the.
Sorry, negative. It can't happen with both RCA and LCA. We are not such an expert to perforate both the right coronary and the left coronary with OS. At least they would not allow us to speak to the lab next time. So it's open to the other teams. Yeah, see. Yeah, coronary camel fistula into the RV, multiple, both from the right side and the left side. So,
ECG is over.
That's only hemodynamics.
yeah, 100 is in.
150 ECG.
150 electrocardiogram. This is a two-part question. Just need to tell me what is happening. I'll show you both the ECGs. This is the first ECG. This put it down. And this is the second ECG. The same patient giving adenos.
Yes. It's initially a fascicular VT, left posterior fascicular VT, then a post adenosine.
Post adenosine, what is happening then in a fascicular VT?
It's it, transit AV blocks.
No, it's not a fascicular VT anyways. It's an unusual complication of adenosine, a clue, which we usually do not see. But of course, we use it recurrently during testings in our lab. Okay. So since now the team is taking, anyone in the audience? AF, yeah. So adenosine induced AF, and it is also the same property of adenosine is often used to check whether the pulmonary vein triggers post ablation in PVI, whether they come back again or not. That was AVRT. It was AVRT, unfortunately. Hundred hemodynamics, 150 hemodynamics.
What is left, sir? Excuse me.
Hmm?
What is left?
100 hemodynamics. 100 hemodynamics, 150 hemodynamics.
100 hemodynamics.
Pretty straightforward. Diagnosis, sir. Team B.
Pressure tracing showing of LV to aorta.
Yeah, diagnosis.
There is a pressure drop from LV to aorta.
Yes, it's a pressure drop, but can you give the diagnosis?
LV outflow obstruction.
I think we are giving a lot of time.
Fixed LV OTA obstruction.
Not sure. I can't give a fix it. Okay. I have not told the pass yet. Please reset it and then now please check the yeah. Team C.
Mid cavity LV obstruction.
Mid cavity obstruction. Should give a more common diagnosis.
HOCM.
Yeah. But do you think HOCM is the only differential?
Subaortic membrane can also.
Subaortic membrane. Yeah. There was unfortunately no VPCs during this trace. Had there been a VPC, you could have clearly shown whether there's a broken bro phenomena. This was actually a case of subaortic membrane. Shall we? Team C, you can choose the next question. There's nothing much to think
200
about.
fluoroscopy.
Huh?
Fluoroscopy 200.
200. This is a bit tough one actually. What is a valve? Yeah.
TTK Chitra.
Huh? TTK Chitra. TTK Chitra actually is not seen fluoroscopically. Team D. Star inverts. Star inverts is what type of a valve? It's a ball and cage valve. So here you can see a tilting disc. Single leaflet valve. Vikram wants to take a try. Jack Shelly, it's not actually the this is not typical of Bjork Shelly. This is Medtronic Hall. Anyways, the closest differential will be Bjork Shelly.
Electrocardiogram.
Electrocardiogram. It's interesting question. So this is the patient post CABG, severe LV dysfunction, baseline LBBB, who presented with septic shock. Okay. So this patient for septic shock, they are given multiple inotropes. This was the ECG post inotropes. After inotropes, patient had a paradoxical worsening pulmonary edema, worsening shock. How to explain this phenomenon? I'll give the. Otherwise, I'll show the echo. Yeah. So this was the echo of the same patient, post inotrope. Anyone in the audience want to take a try? Yeah. Can you please tell your name, ma'am? Okay, thank you. Can you explain what actually happened in the second ECG? More than the QRS widening, anything else? It is actually the P wave merging with the T wave, first degree AV block worsening with inotropes, producing a significant diastolic MR, which is actually worsening the hemodynamics of the patient. We'll go to the next question.
(150) hemodynamics.
Straightforward, actually. But you need to explain all the three, A, B, C, what is happening actually. Team D. Sorry, please.
Aortic stenosis.
Aortic stenosis. It's wrong. At least I'll give one more chance. Yeah, what is it? That is A is a RA trace. B and C are simultaneous RV-LV trace. Can all the 5 teams can go on the buzzer again? No problem. Please reset it. Yeah, team B.
In RA tracing, there is a prominent Y descent.
Good.
Constrictive pericarditis can be one differential for prominent Y descent.
That's okay, but rest of the things. Why? So differentiating between constrictive pericarditis and restrictive cardiomyopathy. What are the features
LV,
would you think suggestive of constrictive pericarditis?
LV and RV tracing go simultaneously at restrictive cardiomyopathy.
Yes. So there is a baseline respiratory variation also you can see. There's no significant respiratory variation in this particular patient, but there's a deep early rapid filling wave. The early rapid filling wave, deep rapid filling wave.
Square roots.
This rapid filling wave, this ascending wave, rapid filling wave, the deep filling wave is very characteristic of constrictive pericarditis.
Square roots.
Square roots, yeah, square roots, and also equalization of the diastolic pressures. So, higher case. This patient is congested. So this is the fluoro of the patient. Can anyone comment on that? No marks for that.
Pericardial calcification.
Huh?
Pericardial calcification.
Pericardial calcification. This is the concentric calcification on the AV groove, complete AV groove in the LA view. Last two questions. I'll just choose one.
200 cath.
This is not an EP question. Of course, this was encountered during an EP procedure. There is a clue. Team D.
Left SVC training into coronary sinus.
Is it the left SVC which is draining into the CS or something else happening?
Actually, from CS it is going on.
So CS can't drain into left SVC, no? There's
Yes.
some problem then. Would you like to repeat this? So, anyone from the audience or anyone from the other teams want to take a try?
Other teams first. Other teams.
Other teams. Other teams excludes Vikram. Yeah. Anyone from the audience? Yeah. Atresia or stenosis, retrograde filling of the left SVC. In fact, there's some issue with the PowerPoint. Stuck. Here you can see the CS initially getting filled, but it's not draining into the right atrium. It is not draining into the right atrium. It is retrogradely filling the left SVC, and in fact, it goes through the connecting cava and comes back through the right SVC, which can be seen faintly on the left side of the screen. This is case of CS atresia or CS stenosis. So only one more question left, so there's no choice. I'll go ahead with it. 50-year-old female unstable angina, post CAG, she develops bilateral visual loss, retina normal, pupil reflex is normal. And to comment on the angio, it was normal. What is the diagnosis? Uh, so I'll give a clue anyways. This is actually very rare complication, more commonly seen with hypertensive emergencies. Team B. Team B.
Posterior reversible encephalopathy syndrome.
Yeah, posterior reversible encephalopathy. Can you comment on the MRI findings also?
Occipital lobe showing hyperintensities.
Sequence? It's okay. They can get half the points. So this is the T2 inversion sequence where there's hyperintensity noted in the occipital lobe. Posterior reversible encephalopathy syndrome, which can be seen with sometimes related to the contrast. Very rare complication. So thank you all the participants and the audience for cooperating with us for this interesting quiz. And the winners for this competition is Team C from NIMS. Thank you. And second place goes to Team Team B with the last minute 200. They get the second place from Osmania. Thank you. Please come on stage, Team B and Team C. Please. Because Dr. Prasad Reddy sir will distribute to the winners from NIMS. Team B, Balachandar and I can know the team from Osmania.
I'm Dr. Balchandar, sir, second year resident from Usmania Medical College.
I am Ganesh, sir, final year cardiology resident from Usmania Medical.